we can start this session now. I'd like to thank you all for attending this today's session on behalf of the Radiology Society of the Egyptian Radiology Society and the Radiology Society in Benha University. I'd like to welcome you all and thank you for your attendance today. And it's my great pleasure and honor to present Dr. Ania Kielar. Dr. Kielar is the Vice Chair at the University of Toronto Medical Imaging, and she did her radiology training in Ottawa, followed by a one-year clinical fellowship at the University of Michigan. Dr. Kielar was an associate professor at the University of Ottawa, and she was the director from the year of 2010 till 2017. And she is the chair of the annual Canadian Association of Radiologists Research and Education Competitions. She's also an associate editor at the University at the Abdominal Radiology Journal. And Dr. Kielar has published over 80 peer-reviewed manuscripts in medical literature and authored more than 15 book chapters. Dr. Kielar will be presenting today about CT MRI LIRADS version 2018 overview and case-based examples. It's a great pleasure having you today with us, Dr. Kielar.
Thanks for having me. So this is exactly what I'm going to talk to you about. I'll try and stay on time because I know you have another speaker after. So what I'm going to do is just give you an overview of LIRADS, and then I have some cases to sort of, use LIRADS on a case so that everybody can get comfortable with it. So I guess the first thing is that I have no disclosures, except that I am actually on the LIRADS writing group and the lexicon group. So I really like LIRADS, and that's why I'm here. The other thing is that everything I have to tell you is not anything that I've specifically made up. It's a team effort. So everything that we work together is as evidence-based as we can make it, given the information we have. And our goal is to help patients. So, standardization, I think, is very important in our world of radiology, whether you're doing a template report or if you're doing a specific report on a particular topic, because particularly for HCC, it's one of the only cancers, at least in North America, where you can send somebody to transplant or surgery without a biopsy. So we need to be accurate. And if we don't use the same technique from one hospital to another, that means a late arterial phase, not early arterial phase, as in an angiogram, in addition to the other sequences, portal venous and delayed. If we don't have the same technique, we can't make the diagnosis. If we do not use the same terminology when we're discussing our findings, then nobody knows what we mean. And if we don't use a template report that asks us about arterial enhancement, washout, and so on and so forth, we might omit important pieces of information. And finally, if we don't use standardized reporting, it's very hard for us to do any data review, like meta-analysis, because we don't understand one person's word and another's. So for example, if we have this lesion or this observation in the liver on the right, we have a portal venous phase, we don't see much, but we do see it on the delayed phase on this gamma-acetic acid MRI. If one radiologist says it's indeterminate, another one says it's equivocal, and another can say uncertain significance, and the same person, if you show them again, might come up with other English words, and you might use other Arabic words or other words. If we don't know what each word means, then it's useless. So that's why we have this numbering system 1 through 5, which basically kind of takes out of the words into numbers so that we can be more accurate. And there's been literature to support the use of standardized terminology. This is a paper that was written back in 2018. And, again, people were using words, so possible, probable, most likely, and then they were transferring that to LIRADS 1 through 5, and different radiologists were using different words and giving it different numbers. And so basically it was causing confusion. Another study showed that if you didn't use a template report, that means it has pre-populated things that it asks you to answer specifically for LIRADS, only 80% of people were actually mentioning if a liver observation had arterial enhancement, which is key for HCC. Only 74% were talking about washout, and only 19% were talking about capsule. And those are the major imaging findings for an hepatocellular carcinoma. Once they implemented a template report, which asks you specifically to comment on those things, the numbers were very high. So, having a template report is important, and using it is key. So our goals in LIRADS is specifically for diagnosing of HCC. We want to use standardized terminology. We want to have consistency in our reports. We want to clearly communicate to the surgeons what we mean so that they can make decisions about the patients. And the whole goal is to improve patient care as well as our ability to do future research. So this is the main template, and I will go through it with you guys in a case shortly. At first, when you look at it, you might say, oh my gosh, this is complicated. How am I going to remember this? The beauty is you don't have to remember it. If you Google LIRADS on your computer, you will get the ACR LIRADS website, which is free, and you could just have this on your desktop and use it every time you need it. Remember, though, that you should only use it for people who are at risk for HCC. So if you see a 32-year-old woman without cirrhosis or any hepatitis B history provided, and she has a liver lesion, you don't use LIRADS for that because their pretest probability of having HCC is low, and things like adenomas can look very similar to an HCC. So we are looking for patients at risk for HCC when we're using LIRADS. So when we look at this template on this table, we look for arterial phase hyperenhancement. That's what this means, APHE, arterial phase hyperenhancement. So does it not, or does it? So depending on what you see on that arterial enhancement, and remember, it's a late arterial enhancement, a little bit later than the typical early arterial enhancement that we use for angiograms. If it doesn't have arterial phase enhancement, then you cannot call it HCC, so LIRADS 5. It still might be, but you can't call it based on the imaging characteristics. It's only if it has arterial enhancement that you can start looking at LR5. The other thing to remember is that things that are less than 10 millimeters by OPTN, which is the Organ Transplant and Procurement Network, Organ Procurement and Transplant Network, and AASLD, which is the American Association for Study of Liver Disease, and many other international liver associations. Even if something looks like an HCC, if it's less than 10 millimeters, they don't call it HCC because they're not going to act on it necessarily, at least not in North America. So this is the template. If there, you can move where the screen is of us, but basically this is what it looks like. So we have non-characterizable, we have tumor in vein, we have LIRADS 1, 2, 3, 4, and 5, and in between we have an LRM, which is not HCC. It's considered malignant. That's what the M is. So it could be a cholangiocarcinoma, it could be a metastasis, and LRNC means non-characterizable. And these are cases where somebody was moving, maybe they had claustrophobia and couldn't continue with the exam. Now, if there's only one series that has some movement, that doesn't mean you can't make a diagnosis. But if the arterial phase, for example, is terrible and the portal venous phase is not great, then you probably would characterize that as not characterizable. I'll take questions at the end. So this is just an example of really not characterizable, because although we do see that there is something on the T2 weighted image, the arterial phase and portal venous phase are just so terrible with emotion that it's very hard to make a comment. I mean, you might guess that there is something arterial enhancing, but in this kind of case, your options are repeat it if they're able to hold their breath, but if they're not able to hold their breath, do an CT, for example. Tumor in vein. Obviously, this is portends a worse prognosis. Most patients cannot have transplant, at least not in North America. And most patients cannot undergo catheter-based therapies. I just had a case the other day where they were being assessed for SBRT, which is stereotactic body radiation therapy. So that's external beam radiation. And they were going to include the area of the tumor thrombus. So, the therapies are changing, and that's why it's important for us to let them know what we see. And then this is just an example of LR1, which is a benign thing. So something like a cyst. Now, most people who have cirrhosis have a very fibrotic liver, and cysts end up getting squashed. So you don't typically see cysts in patients with cirrhosis. However, in the population who has hepatitis B, who are at risk for HCC and don't necessarily have cirrhosis, you may see cysts. LR2 would be something benign, such as a hemangioma, again, more likely to see in hepatitis B. But here's just a non-specific liver observation. We don't see it pre-contrast. We don't see it on the arterial or portal venous phase. But on this gadocetic acid delayed image, we see that it is actually showing uptake of the contrast. So it's probably something benign, but it's indeterminate. Nevertheless, it doesn't look worrisome in this case because we know that HCC is usually dark on hepatobiliary phase, unless it's a very early HCC. But even so, this doesn't look like HCC. So this would probably be benign. This is just an example of somebody who does have a cholangiocarcinoma, because we know that patients who have chronic liver disease not only are at risk for HCC, but also cholangiocarcinoma. So these would be people who have, this is what a cholangiocarcinoma looks like. It's not showing typical arterial enhancement. There might be some peripheral arterial enhancement here, but it's not typical arterial enhancement. And you can see on hepatobiliary phase, it is sort of dark. It shows abnormal signal intensity on diffusion weighted image as well. So this doesn't have a typical appearance of HCC, but it certainly looks malignant. So that would be an LRM. So if none of those apply, so it's not tumor in vein, it's not LR1 or 2, and it doesn't look like something not HCC, and the patient is at risk, then you can use our table. And I'll go through that in an example shortly. We do also have ancillary features. Now, these are things that have been published in the literature that have been shown to be associated with malignancy or with HCC. And, but there's not enough pretest probability or not enough evidence that that imaging feature, such as, fat in a lesion or iron in a lesion, or hemorrhage into a lesion, or dark on delayed hepatobiliary phase, all of those things have been shown in the literature to be associated with either malignancy or HCC specifically, but they're not enough to actually use as a major imaging feature, such as arterial enhancement, washout, and capsule or growth. So what we've done, and this is not super evidence-based, but we've done the best we can with the information we have for now, is that you can upgrade or downgrade something if you want, from whatever you initially characterized it by one category, up or down, depending on the feature that you see, malignant feature or benign feature. But under no circumstances can you actually go from 4 to 5, because the evidence is not strong enough for those ancillary features to be used for diagnosis. But let's say you diagnose somebody with an LR4 observation, and you see ancillary features. Maybe that's a case where they should do a biopsy. And maybe at this discussion at multidisciplinary case conference, they'll say, you know what, this person is at high risk. Maybe we should just operate. So that's up to the surgeon at that point. We're not telling them what to do, but we're giving them some guidance. Nevertheless, you cannot categorize it as LR5. The other thing is, if you see like 2 or 3 malignant features, we still currently only recommend going up by 1 category. And again, you still can't go to LR5. The other thing about these categories and these features in general, whether it's an ancillary feature or one of the major features, I know that sometimes it can be hard to interpret imaging. It can be hard. Maybe it's subtle. Maybe the patient moved a bit. Maybe, you're just not sure. So if you're not sure, we usually recommend going towards a category that's less sure. And the least sure category for us is the LR3. So if you have an probably LR4, but you're not 100% sure about that capsule, you can put it down to LR3. If you're, you see an LR2, you think it's hemangioma, but there's some features that maybe it's not as bright on T2, then you can categorize it as LR3. So whenever you're not sure, you go towards LR3. And from LR5 to LRM. So that's an important feature. The thing is that regardless, we have somebody who has some commentary who's young. That's fine. The thing that's important about our system is that we are trying to go for specificity. So the thing is, we're sending people to the surgery or transplant. We want to be sure that if we're sending them for HCC, it's really an HCC. For us, at least in North America, the worst scenario is that you've transplanted somebody, because we don't have a lot of livers available, and it turns out on explant that it wasn't even HCC. And we know that people with high-grade dysplastic nodules, some of them sit around with high-grade dysplastic nodules for many years before it turns into HCC. So as a physician, our job is to first do no harm and then to help. So if we see something that we're not 100% sure it's LR5, we will downgrade it to LR4. But here's an example of a patient who has an arterially enhancing observation, as you can see on the middle image. And then we see washout, and I think there is a capsule. So this is considered an LR5. If we look on our table here, it's greater than 10 millimeters, and we don't measure on arterial phase. We measure on portal venous or delayed, but not on arterial if possible. Nevertheless, so we've got arterial phase enhancement, yes. So now we're on the right-hand side of this table. We want to know the size. So it's bigger than 10 millimeters and it's less than 2 centimeters. So we're in the middle category here. And now we want to know how many of the other major features are there. So I've told you there's both washout and a capsule. The capsule's thin, but it's there. So I would say that this structure here is a capsule. So now we have two, at least two. I don't know if it was there before because it's the first imaging, so I can't talk to you about growth. Growth means more than 50% growth within 6 months. So if you have somebody who had imaging 2 years ago and you see that it's doubled in size, by definition, we can't call that growth. I mean, it is growing, but we want less than 6 months and 50% increase. Unfortunately, if they're not being seen frequently because they were lost to follow-up, it does sort of mess things up, but we need to see that growth within 6 months. Okay, so this case, we have washout and a capsule. So we have two of these features. So if we're in this category here, and then we go across here, we are now definitely at LR5. This one's a little bit interesting. So if you have washout, that on its own is enough to put it LR5. But if you only have a capsule, and that's pretty rare that you would have just a capsule that shows out, but no washout, that would still be an LR4. So that's why we have this sort of split screen here. Really rare for that to happen, but it does. Okay, so that's LR5. All right, so the idea here is we want to be as close to 100% specific and certain that an observation is an HCC. And it has to be greater than 10 millimeters based on all of those various OPTN, AASLD, and many other international groups, including in Europe, because they don't want to operate on something that's 5 millimeters again, because we know that they will grow over time. But even people with HCC, some of them grow very, very slowly. So until it turns 10 millimeters, they don't call it HCC by definition. And again, don't use ancillary features to upgrade from an LR4 to LR5. We should have no differential diagnosis when you call something LR5. It's HCC until proven otherwise, because these patients may go to surgery or transplant without a biopsy. LR4s and LR3s, they are discussed at multidisciplinary case conference where we come from with surgeons and pathologists, and they can decide based on the patient's preferences and their overall health if they should just continue with surveillance or if they get a biopsy. How do you measure something? Well, we recommend measuring from outer margin to outer margin, including if they have a rim, outer rim to outer rim, on any phase except arterial and diffusion. Both of those tend to overestimate the size of a structure. So we go to the portal venous or delayed. So don't use this or this, outer margin to outer margin. So here we have two liver observations, same patient. They both look exactly the same, but if you measure the bigger one, it was clearly, 18 millimeters or something. And the other one, it was 9. So the one that's bigger would be LR5 by definition. The other one, unless you overmeasure and get to 10, it cannot be LR5. It would be LR4 by definition because it's less than 10 millimeters. Now, in this particular case, the patient will probably end up having both removed at the same time if they're going to get surgery. But, if you only had the one on the left, the more lateral one, then this would theoretically be LR4, and they could get followed up maybe at 3 months rather than 6 months. And if it got over 10 millimeters, then you could do something about it. So what is the evidence behind all of this? Fortunately, because we have more and more studies using LIRADS, we are able to do aggregate studies such as this meta-analysis from 2019 by Dr. Vanderpoel and his colleagues. And basically, they pooled all the data and they showed that when we say LR5, we say that this means 98% malignancy and 95% of them are HCC. So we'd like to be at the 97%, but 95 is pretty good. LR4s, even those, 75% are HCC. So that's why they're discussed at multidisciplinary case conference. But not all of them have to be operated on immediately. So many of them will continue to be followed. And once they change their imaging characteristics or they grow something, then they become LR5 and then you can do something about it. Even LRM, about a third, just over a third of those turn out at surgery to actually be HCC. So there are certain HCCs that don't have the typical imaging characteristics, but they don't look benign. So they end up in this LRM category. But the majority of them are still malignant. So a cholangiocarcinoma, a mixed ICC, HCC, or a metastasis. LR3s, those are the ones that were indeterminate in the past. That's typical words that people use. They can still be malignant, But again, they've shown in studies that if you follow these patients at 3 months or even 6 months, the chance of them going from an LR3 to an unresectable LR5 are essentially zero. They may grow, they can even end up LR5, but the studies have not shown they become unresectable, like tumor in vein, multiple Mets and that sort of thing. But if you do see somebody that's growing or changing that quickly, we know that there are 8 subtypes of HCC. There's a macrotubular HCC. There's, I'm starting to forget the different types of subtypes, but we do know that some are more aggressive than others. So maybe by following them over time and we see that they're changing quickly, that may actually help us in the future to say, you know what, we either need to operate on these more early, or these people won't do well no matter what. So we don't have the data yet, but just to say that if you characterize somebody's LR3, there is still a chance that it's an HCC, but it's unlikely that if you just follow them in 3 months, that they're going to become unresectable, because these people do need to be followed up. This LR2, it's not supposed to have cancer, and this number of HCC being 16% is probably overblown. So they actually talked about that in the paper, that there were some cases where probably it was undercalled and it should have been LR3. So this LR2 and LR1 should probably be less than 10%. This is 0, so that's good. I just wanted to show this, that we do have data showing that our LR5s in the 10 to 19 millimeter range and in the 20 to over 20 millimeter range, they do correlate with OPTN characteristics very well. There's just the LR5 that we call LR5, but it doesn't have that washout. That doesn't work well with the OPTN right now. We're working with them to try and find a way that we can make them equivalent, but we are equivalent with American Association for Study with Liver Disease. So that's at least good. So, and our definition of threshold growth matches that of AASLD and OPTN. So more than 50% increase in size in less than or equal to 6 months. That's why these patients do need follow up on a regular basis. Not, we can't lose them to follow up. And this is, again, the tempo that we use. All right, so I'm just going to move my screen here so I can see better. Okay, so we have our first case here. I've got 15 to get through, and we've got plenty of time to do it. So first case, we have something that's a little bit gray on T2. It's not very bright, but it's not ISO. On a post-phase T1 weighted image, it's not very interesting. It wasn't dropping in signal. But we can see on the arterial phase and on subtraction imaging that it is actually arterially enhancing. And then on the 3 to 5 minute phase, we can see that there's washout and a capsule. So based on our table, if we go to our table, so it's arterial enhancing, it's greater than, I forgot what size it was, 12 millimeters. Okay, so it's between 10 and 19 millimeters. It's got a capsule, and it's washing out. So we have 2 of our characteristics. So we're going to be in the LR5 category. So that one's pretty easy, but it's not always that easy. So here we have same patient with another observation nearby. And this one's interesting because it's actually a little bit darker on T1. Subtraction imaging is also helpful. But it's interesting between the 2 of them that one of them is darker on T1 and the other one is less dark. But that's why subtraction imaging is helpful, because sometimes it might be bright on T1, but it's actually not that arterially enhancing. On T2 weighted images, this one's a little bit brighter, but you can see that they both show arterial enhancement and washout in a capsule. But this one was the one that I showed you earlier that's only 9 millimeters, whereas this one was larger. So even though it shows the major features of arterial enhancement, washout, and capsule, it does not meet the 10 millimeter criteria. And therefore, no matter what we do, we can't, if I go back to that table here, no matter what, we cannot give it an LR5 designation at this time. Now, again, this patient will be discussed at multidisciplinary case conference because they already have one LR5. And it's more likely than not that surgeons, if they do decide to operate, will just cut out the whole left lobe and it's going to be removed anyway. And we also know that LR4 lesions, up to 74% of them are in fact HCCs. But if it was all on its own, this would likely just be followed. But it could still be discussed at multidisciplinary case conference. And if that was the only lesion, there are patients where they would operate or do something about it, like RFA. All right, so that's that second observation in the same patient. Again, once you see one or two, it's important that you look through the rest of the liver to look for other arterially enhancing, other observations. But let's say you have a patient that has 12 of them. Well, LIRADS recommends picking the 3 or 4 biggest ones. You don't have to report every single one. So you can do it in aggregate. So you'll say, there's 3 major big ones. Maybe if you have one in each lobe, because that'll maybe change their management as well. But you could say, there's an LR5 in the left, an LR4 on the right, 2 more LR3s on the right, and innumerable other similar small lesions, probably LR3s. So, or, 10 other LR3s. So you don't have to have a 10-page report where you describe each one. You can if you really want to, if it's a research thing, but generally pick the 3 or 4 biggest ones and leave it at that. Again, how to measure it, it's outer edge to outer edge on a non-arterial phase. And the arterial phase and diffusion tend to overestimate, so don't use those. All right, here we have on a CT scan, we have an arterial phase, we have portal venous phase and delayed phase. So on the arterial phase, we can see that there's quite a bit of heterogeneous enhancement of that right lobe, but actually where the portal vein should be, the right portal vein, it's kind of arterially enhancing, or at least parts of it are. And when we look on the portal venous and particularly the delayed phase, it's not really enhancing properly like it should. So that is tumor in vein. So that would be bad. And you don't necessarily have to even go to the rest of the table that I showed you, because that is categorized as tumor in vein on its own. However, if they do have some specific lesions elsewhere in the liver, you can use LIRADS if they fit in LIRADS with that table, just to give the surgeons a better idea in case they were planning to do something like SBRT for that tumor in vein, or maybe they were planning to use some other, research type therapy. So the main point here is that, make sure you're using LIRADS for patients with hepatitis B or known cirrhosis. The only other caveat for using LIRADS is people who have vascular causes of cirrhosis. So that means people with Fontan procedures, cardiac cirrhosis, hereditary telangiectasias, and Budd-Chiari. Those are like vascular type causes of liver disease. Their regenerative nodules tend to be very similar in appearance to HCC. So we actually exclude that small number of patients from using LIRADS because unfortunately in that particular group of patients, their HCCs and their regenerative nodules look almost exactly the same, and our sensitivity specificity goes down the tubes. So unfortunately, we can't use it in that subgroup of patients. And by the way, if you have any questions that I don't answer, which I'll try to answer at the end, but there is, if you Google LIRADS, there's a whole book on LIRADS that's free. You can download it onto your computer, and we have frequently asked questions in there. And we also have like a 400-page manual. So if you have any questions on LIRADS, you can usually find the answer in there. So, if you have tumor in vein, you don't typically have to talk about individual observations, especially if they're widespread disease. But if there is, let's say, tumor in vein on the right and one extra lesion on the left, I would mention it, and I would be specific about it in your report. All right, so again, keep it simple. If somebody has multiple tumors all throughout their liver, you pick the couple big ones and go from there. So here's an MRI example of the same thing. So arterial phase being the most useful, and subtraction imaging can be helpful sometimes, especially if they've had some hemorrhage or if they've had a biopsy recently. But you can see that there's, this linear area of arterial enhancement along where the portal vein should be. And then here on the coronal, you can see that the portal vein is not enhancing like the hepatic veins and the portal veins elsewhere. I'm just going to have a look at the chat to see if there's anything in here that I really should be answering. Ah, you guys are answering. Perfect. I'm glad. So I'll just minimize you for the moment. Keep answering them. That's great. I would love to have done more interactive, but I wasn't sure. I was worried that it's going to fail on me here, so I apologize. All right. So subtraction imaging, whenever possible on your MRI, if your technologists do it automatically, that's great. If they don't, I would recommend that they do it, especially in patients who have like fatty livers or have iron deposition in their livers. It just makes it easier if you do subtraction imaging to make sure that you're not missing something. And we also know that some of the regenerative nodules can be bright on T1 just because they may have iron or fat in them. And it's helpful to have subtraction imaging to see whether that bright nodule on T1 is actually enhancing or not. All right, so that was tumor in vein, and that basically stops you at this point. Here's another case. So, this is the only phase we see it on arterial phase. It's peripheral. This one's quite triangular. Maybe it's a little bit rounded at the back. But if you see a triangular peripheral substructure, this is a vascular shunt. And most people, I would be very comfortable calling this LR2. Some people would want to call it LR3. But if you see, if it's small, this one's on the bigger side, but if it's small, peripheral, vascular, triangular, call it LR2. If it's more rounded, then you can call it LR3. But vascular shunts tend to be in that category, LR2, LR3. One or the other. If it's more central, then I do call it LR3 for sure. I make sure that I don't see anything else on anywhere else. Diffusion weighted image is very sensitive, but not specific. Look for it there, look for it for T2, look for it on any other post-contrast imaging. But if you don't see it anywhere else, it's still probably a vascular shunt. All right, so they do occur very commonly in people who have chronic liver disease. So it's just worth noting. Sometimes, like I said, they can be more mass-like. And if you see that, then definitely call it LR3. Rarely could you call it LR4. But if you have no other imaging features, if we go back to our table here, so if it's not arterial enhancing and it's not washing out and there's no capsule, then you're going to be left with LR3 no matter how big it is. So as a vascular shunt. If you saw some sort of other ancillary feature, if you saw iron in it, well, then you could maybe categorize, bump it up to an LR4, but that's pretty rare. Okay. This was supposed to be hidden. I apologize. Okay, so we have this arterially enhancing liver observation. Is it very arterially enhancing? I just have to move my image here, our pictures. Yes, it is very arterially enhancing. It's washing out. I don't know that I would call that a capsule. Maybe yes, maybe no. But it is definitely washing out on the 3 to 5 minute phase. So our trend delayed phase. The hepatobiliary phase, it's dark, fine. That's helpful that it's associated with HCC, but it's not enough to be a major imaging feature. However, if we go to our table, so we've got something that's 12 millimeters and it's washing out, but doesn't have a capsule. So it has one feature, but it's the washing out part. So we can still call it LR5. If it only had a capsule, but no washout, then you'd be stuck with LR4. And even though it had the delayed phase, hepatobiliary phase, low signal intensity, we can't bump it up to 5 in this case. But in this particular case, it has washout, but no capsule. So it could be categorized as LR5. So hopefully you guys picked that. I'm sorry, these were supposed to be hidden, but anyway, I apologize. We'll do it together. So on this particular case, on our arterial phase, I would not call that enhancement. Maybe there's a tiny dot of enhancement, but that's pretty subtle. But on our later, that's an early arterial phase, in our later arterial phase, nothing. It's like ISO. On diffusion, I don't really see anything. On portal venous and delayed, it's starting to get washout here. Maybe it's definitely washing out on our 3 to 5 minute delayed, and we have the hepatobiliary phase. So if we just go by, forget the hepatobiliary phase, if we just have washout, no arterial enhancement, and it's only 9 millimeters, if we go back to our table, let me go back, here it is. So if we go to this table, so it's no arterial enhancement and it's less than 20 millimeters, but definitely less than 10 in this case. So we're stuck with LR3. However, you could bump it up to LR4 because we are seeing this ancillary feature. So what are these ancillary features that I keep talking about? So these are things that have been shown in the literature that have been shown either with malignancy, HCC in particular, or benignity. So, if something hasn't changed in 2 years, that's usually a sign that it's stable and probably benign. If it's shrinking over time, maybe it was like a sclerosing hemangioma and they tend to shrink over time. If it parallels blood pool on all phases, maybe it's a vascular shunt, or maybe it's fat. If it has undistorted vessels, again, most lesions are causing vessels to go around it, not going through it. I mean, obviously you might want to think about lymphoma, which can have vessels going through it, but that's not super common in patients with cirrhosis. If it has a non-enhancing capsule, that's associated with HCC. It's one of our major imaging features, but it's not that commonly seen without washout. If you see something called nodule in nodule or mosaic architecture, which I'll show you later, that's very associated with HCC, but on its own, if it didn't have arterial enhancement or all these other features, I mean, it almost always has those other features, but if you saw mosaic architecture, that's definitely associated with HCC. If you see blood products in a mass, unless they had a recent biopsy, that's usually associated with HCC. And if you see a drop in signal intensity on the post-phase images compared to the background liver, that's also associated with HCC. There are other things that are associated with malignancy in general, not necessarily HCC, but maybe also HCC. So if you see it on ultrasound, when we talk about things on MR and CT, we usually call it an observation, not a lesion. Why? Because we see things like vascular shunts. If you cut that up, that's not a lesion. There's nothing there. It's just a vascular shunt. It's more venous drainage through a capsular vessel or more supply through an arterial capsular vessel. So they're not actually lesions, and you don't see them on ultrasound. So if you don't see it on ultrasound, it's not necessarily a lesion. If you see it on ultrasound, it's a lesion. Now, people can have focal fat in their liver, and they can look like a lesion. And in fact, if you cut it out, you will see that there's fat there. So that is theoretically a lesion. On MR and CT, we'll see that, and you'll see it on ultrasound as well, but you will not see vascular shunts. So if you see something on on CT or an MRI, we typically call it an observation. If you see something on ultrasound, we'll typically call it a lesion. Something that's growing but too slowly for our definition is associated with malignancy, but not always, because we know that a hemangioma has to get to its final size. Some people have huge ones, and you see these patients at age 30, and at age 50 they're way bigger, but they tend to be slow growing. Mild to moderate T2 hyperintensity can be associated with malignancy in general. So that's sort of gray T2, not bright T2 like a cyst or hemangioma. So that is associated with malignancy, but not enough to be a major feature yet. Corona enhancement, because we know that malignancy tends to parasitize other vessels, so they get that corona enhancement. If you have focal fat sparing or iron sparing inside a lesion, that's usually associated with malignancy, but not necessarily HCC. And then if you have that low signal intensity on hepatobiliary phase or transitional phase, again, more research is needed, and maybe in the future it will be a major feature for HCC, but for now we have it as an ancillary feature. Oh, sorry. So this would be an example where we didn't see arterial phase enhancement, but we see it on the peripheral, it's delayed phases, and that's just an example of an ancillary feature that favors malignancy, but at this point is not definitive for HCC at this point, maybe soon. So in that particular case that I showed you before, because it didn't have arterial phase enhancement, no matter what it is, we can't call it an LR5 because by definition, you have to have arterial phase enhancement. But we know that LR4 can be up to 75%, can be HCC. So those cases should be discussed at multidisciplinary case conference. And depending on the patient's other situation, other factors, maybe they had a prior HCC that looked like that too, maybe that will compel them to operate or do something about it, or maybe do a biopsy, or maybe follow them up. So again, ancillary features can go up or down by one category, no LR5. All right, next case. Oh, one other thing that LIRADS has is we do have management suggestions. Again, we're not telling the surgeon what to do. We're not saying you have to operate. However, we know that patients with risk for HCC should continue to be screened. Whether they get screened with ultrasound or if they get screened with MR or CT is debatable, depending on your country of origin and how many MR and CTs you have. But in Canada, we don't have a lot of MRI machines out there, so we don't screen people with CT or MRI typically. They're usually screened with ultrasound unless they have a very cirrhotic liver and we can't see through their liver, or they have a very large body mass index and we can't see, or a very, very fatty liver. But anyway, most of these patients need to be screened either with ultrasound or CT every 6 months. If we see an LR3 lesion or observation, they should be screened either 3 or 6 months, somewhere in that range, probably with CT or an MRI, so that we can compare apples to apples. And again, LR4 is multidisciplinary case conference, and even LR5. We're diagnosing HCC, but maybe the patient isn't a good surgical candidate, and they're just following them for the sake of following them. And LRM, we know that it's malignant. We don't know that it's an HCC, could be something else. And, the surgery or treatment for a metastasis or cholangiocarcinoma may be different than what you want to do for an HCC. So those should be discussed at multidisciplinary case conference as well. All right, here we have another case. So we have an observation, it's 11 millimeters, and it's got arterial phase enhancement, and it's washing out. You know what? This theoretically actually should be an LR5 because it's washing out without capsule. That should be LR5, not LR4. If it was 9 millimeters, it would be LR4, and you can't make it LR5. So I apologize. This should have just been LR5. If we knew it grew, then that would be LR5 anyway. If it just had a capsule but wasn't washing out, then it would be LR4, and growth would really matter. Apologies on this one. All right, so forget that. All right, so actually the teaching point for this is there are different centers that use different protocols for scanning patients at risk for HCC. Obviously, a late arterial phase is very important, and a portal venous phase is very important, but we do recommend having a 3 to 5 minute delayed phase on CT and MRI, because occasionally you don't see that washout very well on the portal venous, and it only shows up on the 3 to 5 minute delay. And you should look at those as well to get your final decision as to whether there's washout. Okay. Here's an example of a patient who has peripheral arterial enhancement. And as we go on in our portal venous phase and delayed phase, it's like slowly enhancing more and more. So this is not typical of HCC. We have to say that this is an LRM. On the hepatobiliary phase, it's showing that it's consistent with malignancy as well. It's got that gray T2 that's not very nice looking either. So your differential diagnosis for this would probably be cholangiocarcinoma. We can also see the bile duct dilation, which is very abnormal, particularly for cholangiocarcinoma. We have seen cases where there is more arterial enhancement here, and it looks like there might be areas that wash out. And we know that 1% of cases are actually a combination of hepatocellular carcinoma and cholangiocarcinoma. So that's why some of them look very strange. This one is a very particular or very characteristic of cholangiocarcinoma. So this would be categorized as LRM. And in that case, you don't really need to go here because there's no point. So they can occur cholangios in patients with cirrhosis. Again, look for those delayed uptake or persistent uptake. Look for that rim enhancement, arterial phase enhancement, because we're looking for non-rim arterial phase enhancement for HCC. And just like METS and cholangiocarcinoma, HCC, cholangiocarcinoma will be hypointense on the hepatobiliary phase on getocetic acid MRI. All right. So here's just one more companion case. This is what it looks like. It's got that gray T2 that's not bright enough to be a hemangioma or something benign. On the arterial phase, there is some peripheral enhancement, but it seems to be filling in more and filling in more. So this is typical. This patient actually has an interesting finding here that on the arterial phase, you can actually see something enhancing here. It's not that obvious on T2, and you can see it on the portal venous phase. It's less obvious. Maybe it's the wrong cut, but it's, I think this person actually has 2 cholangiocarcinomas. So just because they have one doesn't mean they can't have another one. So it's worth looking through the liver to make sure you're not doing a satisfaction of search type error where you found one but not the other. So again, with this, you wouldn't even use this diagnostic table because it's LRM. So LRM. This one was interesting because I would have called this one LRM as well, all day, every day. We see a sort of intermediate signal intensity on T2. On the post-phase imaging, there wasn't really much dropout. It was dark to start with. On the arterial phase, we have rim enhancement. So that's not your typical non-rim arterial enhancement. And it's, it's got this like central filling area. So this really doesn't look right for HCC, but they had a high AFP and they underwent biopsy, and it turned out that this was in fact an HCC. So, if you remember that table that I showed you, here it is, up to 37% of LRMs are still HCC. And we know that there's 8 subtypes of HCC. So there are certain rarer subtypes of HCC, which may not, that the cirrhotic kind particularly of HCC, which don't necessarily show that typical arterial enhancement. And because they have all that sort of fibrous tissue, they take up like an HCC. So that was a path-proven HCC. One thing that's worth mentioning at this point, because I'm not covering post-therapy appearance of imaging, but if you are following somebody who underwent, I don't know, RFA or microwave ablation or even SBRT, when you do look at their liver lesion, you can call it a lesion at that point because we know that it was treated. If you see imaging characteristics that looked like the lesion did before it was treated, so in this case, we had a case where it didn't have the typical arterial non-rim enhancement. If you see something develop in the same location or maybe in a different location in the liver that has the same imaging characteristics as the thing looked like before, then you should say this is very highly suspicious for either residual or recurrent disease because it has the same imaging characteristics. So even if it doesn't now have arterial enhancement, if it previously didn't have arterial enhancement, we don't expect it to in the future. So that's just an interesting point to be aware of. Okay, so another pearl here is that, some people with cirrhosis and chronic liver disease have very heterogeneous livers. It's mostly because they have a lot of regenerative nodules. So sometimes it can be really hard to pick out what is actually a lesion versus not a lesion, or an observation versus not an observation. So that can be challenging. So this person has all of these like little fibrotic nodules, whatever, but if you find one that looks different than the others, so for example, yesterday I was reading a case, none of them showed arterial enhancement, but there was one that was more washing out. And this one also actually showed a drop in signal on a post-phase imaging. And we know that fat in the lesion is suggestive of HCC as an ancillary feature. So to me, that was enough to actually call it, even though it didn't have arterial enhancement, it showed features that were LR3 here, but it also showed that ancillary feature. So I bumped it up to LR4. So in this case, the rest of the liver I would ignore, even though they all look sort of nodular, but this one is different from the others. And this one you can assign an LR4 category, whereas the rest of the liver don't, but this one you would. But again, this is why sometimes interpretation of these livers can be very difficult and very time consuming. So if you have all of your various sequences up and you can, link them so that they're all sort of scrolling at the same time, as you look from one sequence to the next, you'll be able to see if one of the lesions or one of the observations is very different from the rest. So this is just a bonus case. I don't know about you guys, but I don't feel comfortable in this case to definitely call this an HCC. But I personally, I can see that there's washout here on these delayed phases. I can see that there's something abnormal on this phase. On portal venous phase, I really don't think I can say that there's a capsule. Maybe there is. I don't know if this is the same. I mean, this is obviously pulsation artifact here. I don't know if I'm getting mixed up here with my IVC or if there's actually something arterially enhancing. So this is tough. And I would be more comfortable saying that this is LR non-categorizable than something. And this person might do better either repeating the MR or maybe having CT, because we know that CT, the images are acquired instantaneously. So even if somebody is, has COPD or whatever it might be, they're probably able to get the images to be at a diagnostic quality. So that would be non-categorizable. Just a reminder of ancillary features. So I'm going to show you a case. So here we've got on T2 weighted images, we have something that's sort of not very bright T2, but it's certainly not ISO to the background. Here it is again on T2 fat saturated images. And we can see there's restricted diffusion on diffusion weighted imaging. So now we have two ancillary features. So even if it doesn't have all the other features, whatever it might, I didn't show you all the rest of the case, but if, let's say it was LR3, you could bump it up to LR4. If it was already LR4, don't bump it up to LR5 because by definition, we can't. And again, if you weren't sure if those ancillary features mattered or not, or if you don't feel like looking them, just keep them where you were. If you were at LR3, just stay at LR3, LR4, stay at LR4, because we know that these patients will continue to be followed. The difference here between LR3 and LR4 is maybe this person, if you did bump them up, would be discussed at multidisciplinary case conference, and it's possible that the LR3 person would just have follow-up imaging at 3 to 6 months. So again, it just depends on how comfortable you are with the ancillary features. On CT, if we look back at some of these ancillary features, a lot of these are actually very specific only to MRI. So, we can't really look at fat sparing or iron sparing on CT. We don't always see corona enhancement. Maybe you would on CT, maybe not. Obviously, ultrasound is ultrasound. Transitional phase and hepatobiliary phase is specific to MRI, and restricted diffusion and T2 weighted images are also. So a lot of these ancillary features are specific only to MRI. So if you're following your patients with CT, you may not actually be able to talk about a lot of these ancillary features, which is why in the studies that look at MR versus CT and looking at agreement between physicians or radiologists reading them, you'll see that there may not be very good agreement between LR3 and LR4, because sometimes you might upgrade somebody on MRI, whereas you can't on CT because you don't have the imaging features. But LR5, we are pretty good between CT and MRI. Here's just an example of that mosaic architecture. So, it looks like almost lesion inside a lesion. The other thing that's kind of neat about this particular case is that you can see that on T1 in-phase images, there are areas of high signal intensity which drop on a post-phase imaging. So this is very specific if you look at the ancillary features of fat in mass. So it's dropping, certain parts of it are dropping in signal intensity. And it also had the mosaic or nodule in nodule architecture. So these are all specific for HCC. But even without all that, like there is arterial phase enhancement, and these arterially enhancing areas are definitely washing out. So, and it's big. So this is HCC regardless of these ancillary features, but this is just a neat example. This person, it's the same person that I just showed you with that mosaic HCC, actually also had a hemangioma, which is kind of rare. And this is actually a sclerosing hemangioma. So it's bright on T2, but you can see that it actually has some features that it's starting to pull in, and over time, it might actually shrink in. So that's kind of a neat example that you can see. All right, just in the last two cases here, just to make everybody comfortable. So we've got a lesion here. We don't see a pre-contrast. On T2, it's a little bit bright. On diffusion, restricted diffusion, maybe. It's arterial enhancing, and there is a washout and a capsule. So this is a typical LR5. Just in case I was confusing you with some of the other cases, that's what we're looking for. And oh, that was my last case. So basically, LIRADS is our way as doctors across the across our countries, across the world, to use the same language, regardless of what language we speak ourselves and what my friend might say in English versus me. So it was designed by radiologists as well as surgeons and pathologists. So we didn't do this by ourselves in LIRADS. We have people from transplant surgery, pathologists, and even we've had some patient input to create a language for us that helps us to talk to each other in our multidisciplinary case environment. And I strongly recommend that you use this algorithm and the tables to help you with your categorization. And again, these ancillary features, maybe they're a bit confusing at the beginning, but once you get comfortable, they are helpful. But currently you cannot upgrade to LR5. So these are my colleagues that I work with very closely, and I want to thank all of them. And if any of you want to get involved with LIRADS, we're very happy to get people. We have people from Egypt already involved, but give me that's my email if you want to contact me. I think we have just a couple of minutes left. So if somebody has a question, let me just see. So if you guys have any questions, so if somebody has a question here, when combined HCC and cholangiocarcinoma, what should you call it? I mean, most of them will look funny. So we will call it LRM by definition. If it's path proven, then you just call it that this is an HCC cholangiocarcinoma. So don't even use LIRADS for the path-proven lesions. But if you are looking around for other lesions or other observations, then the other ones you would call LR 1, 2, 3, 4, 5. But if you have something that's path-proven, you say this is a path-proven, whatever it is. What if they have LR4 and LR5 lesion at the same time? So you need two separate ones? Yeah. So when in your report, you would say in segment 7 of the liver on series 5, image 22, there is a arterial enhancing washout 12 millimeter lesion consistent with LR5. In segment 2, that's what you would, I'd say there's a 9 millimeter arterial enhancing washout, whatever, LR4. So be specific, give the image number, say where you're talking about. So the next person, I mean, hopefully on your packs, you can leave, a measurement so that the next person knows what you were doing. Ours, unfortunately, is a little primitive and we don't do that. So we say what image number, what series, because let's say they go to another hospital, they may not have your imaging. So the more information you give, the better. Should capsule be a complete circle around the liver lesion? Great question. Usually it is, but sometimes you'll notice it's beside a vessel or it's beside the edge of the liver and you just don't see it fully. So if you see a partial capsule, that's where you have to either ask a friend to ask them if they think that it is. But it's really your discretion if you feel that it's enough of a capsule. I would also look on coronal because maybe you'll see, 3/4 is, and then you can say yes. Should we measure on T2 or portal venous? So I would use portal venous or the 3 to 5 minute delay if I can. If you don't see it on anything other than T2, use T2. If you only see it on arterial, we say you shouldn't measure on arterial, but if that's the only place you see it, or diffusion, you can say this is the only place I see it, and that's how big I'm measuring it. Yeah. So if I had portal venous as a choice, I would pick portal venous over T2. If I didn't see it and I had T2 over arterial, I'd pick T2. Is there any other question I've missed? I'll just look through here. All right. Well, you guys have 3 minutes to have a bio break before your next speaker.
Yeah.
So why don't you do
Thank you very much for this very outstanding lecture, and it was great pleasure having you, and hopefully we look forward to having you again with us in further lectures. And thank you very much.
Thanks so much and all the best.
Thank you very much, Dr. Kielar.
Bye.
Thank you. Dr. Gosselin, are you here with us?
Yep.
Yeah.
Right here.
Yeah. Nice having you with us today.
Oh, thanks for having me.
Yeah. Would you mind if you please share your screen, please?
Yeah. Share the screen. Here we go. Okay. All right.
Okay. So I would like to introduce Dr. Gosselin, and like to first thank you all again for attending this session today. On behalf of the Egyptian Society of Radiology and Nuclear Medicine and the Radiology Department at Bena University, I'd like to thank you all for attending today. And I'd like to thank Dr. Hisham Sheikh for coordinating this session today. And it's my great honor to present Dr.Marc Gosselin. Dr. Gosselin, he is a full-time professor at Oregon Health and Science University. He did his radiology residency at University of Vermont, and where he served as the chief resident. And he did his fellowship of thoracic radiology at Stanford University. Dr. Gosselin is the former residency director at University of Utah. And today he will present today on conceptual approach to chest radiograph, diffuse lung disease, thin section CT approach. It's a great pleasure having you, Dr. Gosselin, and you might start the lecture. And thank you for giving us a lecture for the second time. Thank you very much.
Oh, my pleasure. My pleasure. How's it going, everyone? I'm going to talk to you a little bit about, old school stuff. That's where we're going to go. Chest radiographs for the first part. And then the second part will be more of the thin section CT, kind of focusing on a conceptual approach to lung diseases. Lung diseases in general are a bit confusing. A lot of the terminology is a little bit confusing. So we're going to go through this. Now, to start off with these objectives, one of my mottos that I used to say going to work every day was where we all think alike, no one thinks very much. And that's true in a lot of areas in life, but especially in medicine. And one of the things I've noticed in our chest radiographs, they're actually probably, in my opinion, one of the most difficult to read well. And many, many of the residency programs and curriculum, even in medicine, they scrape the surface of what you can diagnose with the radiograph. Radiographs are considered, archaic. And it's like, well, that's not necessarily true. It's a snapshot of the patient's cardiopulmonary status in a moment of time. It is difficult to extract that information and then put it together. So one of the things I've noticed is the traditional teaching of most pulmonary diseases is, I think, outdated. I don't think it works very well. I don't think it translates to very good reports. And we tend to get into a rut of sort of saying the same thing, especially with like ICU imaging or such. So what I'm going to do is I'm going to try to shake it up a little bit for you. When I teach this to the residents, this is the format in which I teach. Okay, so I'm going to take you through it. I'll be transparent with my thinking. Feel free to ask questions if you have any, or email me. Okay, so let's just start off. And also, I sent over a differential card, which hopefully you have access to at some point. And I'm going to show you how to use it. Okay, we're also going to talk a lot about terminology, about some of the things we put on the report. And, terminology, some people object to some things I might say. Yeah, if you want to, you can. Be careful with it, though. I've thought about this a lot. So, and the other thing we're going to talk about, and based on the card, is using morphology and distribution, putting them together, and you can come up with a pretty reasonable differential, pretty short differential, or just a diagnosis. So let's just start with the basics. Normal chest radiograph. We read a lot of these. Still, even for an archaic thing, this is still a workhorse in most radiology departments. So one of the things, the hallmark, and it's just a quick review, but it's such an important concept, is that we tend to see things, organ boundaries, because of a difference in density. Okay, that's the hallmark, whether it's ultrasound, MR, CT, radiographs. And the chest radiograph is beautifully set up for that. Okay, beautifully set up. It's because the vessels with the soft tissue, the blood, stand out beautifully against the background of the lungs. And we tend to see these margins as very sharp. And that's kind of the crucial thing. A lot of teaching I've noticed is they kind of take that concept, but they don't really apply it effectively. Like some of the teaching I hear is, oh, the heart border is obscured, the diaphragm's obscured. We're using something that's not even in the lung. I mean, it can be helpful, I guess, for localization, but more often than not, it's going to lead us down the wrong path. Try to develop that approach for radiographs by focusing on the vasculature. They really should be sharply marginated, and that's a good sign that there is nice aerated lung around it. When the density starts to increase in the lung, maybe from edema or pneumonia, then the vessel margins start to get blurry, and then they just completely disappear. And that's kind of what you're trying to develop your perceptual skill set to be when you approach radiographs. Don't worry about, well, I don't see the diaphragm a little bit here. The vessels look sharp. Don't worry about it. Okay. What determines density? Well, there's two things. One is atomic weight, right? Bone's going to stop more than air, right? And the other thing, and this is important, is tissue depth. And I'm going to show you why that can be important when you evaluate the mediastinum. So tissue depth is, right, it's the same density, but the thicker it is, the more likely the photons will get stopped along the way and not reach the screen, therefore becoming more white when it's exposed. So an example of what I'm talking about. This is a person over 3 days developed a cough. Take a look at the right lower lobe vessels. You look behind the diaphragm, they're nice and sharp. That indicates well aerated lung. Well, after 3 days, you notice that the vessel margins are blurred and a bit more obscured. And in some cases, you just can't see them. You just can't see them. And the other thing that starts to develop is now you're starting to see the bronchi. Now, normally we don't see the bronchi, on a radiograph because air, and it has surrounding air in the lung. Same density, don't see where one begins and one ends. When the lung starts to become more opacified for whatever reason, then these airways tend to stand out and the vessels are the ones that are obscured. Okay, this was a right lower lobe consolidative pneumonia, bacterial. Another patient, 17-year-old, sudden onset of shortness of breath. And you can see that the vessels are not well distinct. This is more consolidated, a little bit more ground glass. The other thing you notice is you shouldn't see the diaphragm all the way through, right? The continuous diaphragm sign. The heart and the diaphragm and abdominal structures have a similar density on radiograph. Therefore, you don't know where one begins and one ends. When you can see that border, you know by definition there is air within the mediastinum, and this is a pneumomediastinum. So sudden onset of dyspnea, coughing, alveolar rupture, air leaks into the mediastinum, right? Differences in density. Just as a caveat, this we would call a consolidation. A consolidation is simply a descriptive term that it indicates that there is increased ill-defined opacity that you cannot see the vessels. And you'll probably see some air bronchograms, although not always. Ground glass for a radiograph is when there's increased areas of opacification. The vessels are blurred, but you can still see them. Now, these are just descriptions, but they will help you in your organization, especially if you use the card, by looking in those particular categories. Can you use ground glass on a radiograph? Absolutely you can. For those who still teach you can't, please stop. Okay, please stop. The original description of ground glass is from 1971, Fraser and Perret. It was actually considered the first manifestation of various diffuse lung diseases, and it was described as a speckled increased area of opacification where the vessels are blurred but still seen. It was later applied to the CT, and then some people wrote papers and said you can't say it on a radiograph. That's not true. You can see it better on a CT, but you can see everything better on a CT. So if you see it, call it. Now, differences in density can also be used for things like pleural effusion. When I was learning about radiographs, my faculty used to say, oh, it's like a veil, and then they would wave their hands of opacity. And once I see this, I just hand waving, I know that they don't really understand it. So what it is that you can still see, for the most part, vasculature. There is an area of increased opacification and whiteness. You can still see most of the vessels. There are some air bronchograms here. It's probably atelectasis, but you can see it. As opposed to this side, which you really can't see the pulmonary vasculature. It's opacified as well, but the vessels are more difficult to see, if not impossible. So what you would say is, yeah, this is a pleural effusion, that the abnormality that's stopping the beam is outside the lung, but there's still air around the vessels, hence we can see them. That would be indicative of pleural effusion. When you have increased opacity and you can't see the vessels, that would tell you, this most likely lies within the lung. That's where the problem is, and your differential would then go in that direction. Okay, they CT this person anyway, but you can see large pleural effusion on the right, consolidation on the left. Okay. All right, now this is going to be I'm going to step back a little bit. I spent a lot of time teaching and working in the medical school with their curriculum transformation. And what I started to discover was that many things in medicine are not taught in the correct conceptual format. We tend to teach based on diseases. So we teach about a disease, and then we talk about the signs and symptoms that they can have, rather than teaching from a signs and symptoms based learning. That's kind of how I learned at McGill University in Montreal. And that's what that format was. And that's a better format because this takes you in the direction of critical thinking that you want to have. A patient presents with a sign or symptom. You then go through their history and physical, knowing a little bit about the specificity and sensitivity of these particular signs and symptoms, coming to a post-test, or post-history probability. And then you decide, well, I know the diagnosis, or this test will help me. As opposed to when you're disease-based, a person presents with a sign or symptom, you're not really sure how to approach it. So you end up probably ordering a lot more examinations than finding that diagnosis and then going, oh, now I know what it is. This is what we tend to do. So it's also true in radiology. And so the analogy I'm going to have here is that we're presented with a radiograph of somebody. On the radiograph are some findings. There's a morphologic findings, and then, very importantly, there's the distribution of the disease. This is the radiology kind of analogy to signs and symptoms. So this is how that card works. It is basically the morphology of the abnormality in the lung or mediastinum, and then it's the distribution of that disease. And then you look on the card and see what are the most likely diseases that tend to manifest with this particular morphology, and then this particular distribution. Then you would look in both categories and say, hey, there's only one disease that's in both. Therefore, it is most likely that. Now, this may sound a little strange, but airspace, don't use it. It does not help you. You think it does, but it really doesn't. Interstitial doesn't really help you. Terms like reticular nodular, that's thrown out all the time. When I see that, I kind of assume that the radiologist is not sure what they're talking about, and they just kind of put that word in there. It sounds good. And avoid the term infiltrate. I don't know if you use it, don't use it. Now, the reason I'm saying airspace and interstitial are not helpful is because pathologists have shown us that in the lung, almost 99.9% of the time, both are present. So it's an artificial division, and it leads to vague terminology like prominent interstitial markings. What does that mean? What does that mean? I don't know. It leads to long differentials because you have two categories, and it tends to be very long. I've actually seen papers written in our journals that said, like mycoplasma pneumonia is a classic manifestation of a mixture of airspace and interstitial opacities. What does that mean? Wow, it's differential of everything. I don't even know what that means. So I'm going to try to encourage you to break away from using that. Look at the morphology. Is it a consolidation? You don't say airspace, it's consolidation. Is it a ground glass? Is this reticulation? The other thing is that it's like real estate. It's location, location, location. Only certain diseases can occur in the lung in particular areas. There are a lot of microenvironments that affect manifestation of disease. So between the two, this should give you a reasonable approach and hopefully shorten your differential, tighten up your reports that hopefully, you look at and you go, yeah, I kind of like that report. Okay, duration of symptoms is another key thing. So if you're talking about symptoms that probably are less than a week, we kind of put that more into the acute category. And when symptoms are, longer than a week, especially longer than 2 weeks, you start thinking about more chronic diseases. Okay, these are the morphologic descriptive terms. Okay, consolidation. Is it acute or chronic? Is it less than a week, or is it longer? Ground glass. Again, you can use ground glass on a radiograph. Again, if you teach that you can't, stop. Reticulation, that is just lines. Reticulation kind of means webs, and the lines are, how you can tell is that they are often not branching. They may undulate, but they don't branch. Nodules, cavitary, non-cavitary, distribution being very important here. Peripheral lace-like, that means kind of a lattice. You have crisscrossing thick reticulation. That's almost sometimes looks like even the nodularity in little holes. And then you have the curved reticular, okay, curved reticular. So it's reticular, but it's curved like a comma, just like a comma. So it looks like there's some commas. The budding tree, you can see this on the radiograph, by the way, but I'll show you a couple of examples. And then, mosaic lung attenuation, which is probably a bit more suited to the CT. Again, infiltrate is not an accepted term. It is not an accepted term. This would be an example of a consolidation. Increased area of opacification, can't see the pulmonary vessels. You see some air bronchograms. This is more of a ground glass pattern. Ground glass being kind of like a thick fog or a frosted pane, shower glass door. Someone walks in while you're taking a shower, there's someone there, but you don't know who it is. That's kind of an example of ground glass. The vessels are indistinct, they're blurry, but you can still see them. Again, it's just a descriptive term, and airspace or interstitial, irrelevant. Reticulation. You can see these lines, they're non-branching, they undulate. This is a reticular pattern. This is actually septal thickening. Nodules, multiple nodules. You can see they're not vessels on end, and how you can tell that is that there will be a vessel of the same caliber coming towards it, and that would indicate that this is just a vessel on end and not a nodule, no matter the density. But when you see something here and there's no vessel coming towards it, that would be a nodule. This is the peripheral lace-like pattern. These are thick reticular opacities that are crisscrossing little holes. And then this is an example of the commas, the curved reticular opacities. And on the card, you have your differentials that tend to manifest with that. So now let's shift to the second part. The other part of the card is based just on distribution. Is it upper lobe? And that's the mnemonic I use because I like this one, set part, because the most common, there's 2 for each, are in the first 3, and these are less common. Bronchovascular is a descriptive term that really means kind of perihilar, radiating out from the bronchi. And there's not a lot of diseases that tend to do it. So even if you're not sure of the morphology, just by seeing the bronchovascular distribution, your differential is like, 2 or 3 things. Peripheral, random, diffuse, which I'm going to talk about specifically, diffuse distribution, because that often indicates a systemic injury to the lung, where the whole lung, both lungs get uniformly injured. And then there's focal, multifocal, and lastly, dependent, or what I would refer to as gravitational-based abnormalities, like hydrostatic pulmonary edema or pleural effusion/aspiration. Okay, so this would be the consideration of distribution. These are reticular opacities, but you can see there's also consolidation, and it's worse dependently and medially. This would be a gravitational. This is characteristic for congestive heart failure. These are randomly distributed thin-walled cavitary nodules that vary in size and have fluid levels. In this case would be pretty characteristic for septic emboli, but sarcoma mets maybe. This is an upper lobe disease process. There's reticulation. There is some associated nodularity, but notice the hilum. The hilum are pulled way up here, pulled up. And that is actually a sign of chronic upper lobe disease. And you would go down the sec part, and most likely the disease is in there. This is the one I showed you before, more of a diffuse injury. When it's diffuse, you think of systemic. In this case, this was a 17-year-old who tried heroin for the first time, and it didn't go so well for them. This is more of a non-cardiogenic edema kind of manifestation. And this would be an example of bronchovascular. You can see how the disease sort of radiates out from the hilum, has a slightly upper lobe distribution. You'd look on bronchovascular, you'd look on upper lobe. There's some associated nodularity. What's the diagnosis? That's sarcoid. What's your differential? I don't have one. It's sarcoid. Do you need a CT? No, you don't. Again, how we organize our information and approach. To hammer home the distribution in lungs in this microenvironment, I want to just kind of quickly just review a little physiology. And this is a patient who has chronic renal failure. And you can see there's a little subperiosteal reabsorption of the clavicle, osteopenia and stuff. Lots of calcifications within the apices. Why the apices? Most people still teach, they still do, that these diseases in the upper lobe are because of high oxygen. Like, oh, cavitary tuberculosis occurs in the upper lobes because of high oxygen. That is wrong. Wrong. It's not. That's from 1939 or whenever that was, and we still teach it. Has nothing to do with it. The oxygen thing has been used exclusively. Just from here on in, it's upper lobe. It's not oxygen. It's lymphatics. It's, the pH. It's, something else. In this case, it's the pH. The upper lobes have a lower CO2, but a higher oxygen. What's the pH in the parenchyma and in the alveoli in that microenvironment? It's alkaline. The lower lobes has a higher oxygen or lower oxygen, but a higher CO2. So therefore, it tends to be a little bit more acidic. Where does calcium tend to precipitate out? In an alkaline environment. So this is called metastatic calcification, which is seen in secondary hyperparathyroidism or renal failure. And it characteristically deposits in more alkaline environments, and in this case, the apices. All right, so this is the card, and hopefully you have it, and I'm going to take you through how to use it, and then see how it works for you. Again, this is based on what we would call the signs and symptoms. We have a patient who has this morphology and this distribution. Is it acute or chronic? You got consolidation, you got ground glass, you got crazy paving, you got cavitary nodules, multiple nodules. These are the distributions, and then you give your differential. This is the back part of it, and it talks a lot about the distribution here, and it goes through them. And the distribution is gross distribution within the lung, and in the next talk, we'll kind of focus it down a little bit more into the secondary pulmonary lobule distribution and how that can help you. Again, airspace interstitial, not important. It really doesn't change your differential and your thinking. I also got a bit about mediastinum, hilum, and even a bit of cardiac. Okay, that's the card. So let's see how I use it. 30-year-old with a dry cough and fever. Okay, we take a look. It's not normal. The vessels I see very well down in the lower lobes, but when you get to the perihilar and upper lobes, they're very difficult to see, but I can still see them. So how would I describe this? I would say that this is a ground glass process, and it has an upper lobe distribution. So we would take a look in the acute ground glass, see what diseases are there. And then I would take a look at the upper lobe on the other part of the card. What are diseases there? Now, which diseases or disease is in both? And in this case, it's, pneumocystis. Okay. I guess it's pneumocystis. I don't really have another differential at this point. So that would be my report. Is it airspace or interstitial? It's irrelevant. Let's call it airspace. Well, how's that change? I don't know. Let's call it interstitial. I don't know. What? You can't tell. Both are always present. It doesn't matter. Now, quickly, diffuse distribution. Now, what I mean by diffuse is that it is uniform. In the acute setting, this is acute, less than a week, almost always the etiology for this is going to be a systemic injury. It'll be something like coming outside the lungs, like trolley or sepsis, and it injures the lung uniformly. Or if it's a pulmonary hemorrhage syndrome and it's diffuse, then yeah, you're talking about some sort of systemic cause, pulmonary renal of pulmonary hemorrhage syndrome. So focal diseases more commonly reflect a local disease process, something like bacterial pneumonia or contusion and trauma. Okay. In the chronic setting, this doesn't work as well, but in the acute setting, diffuse distribution, you start thinking about non-cardiogenic edema and pulmonary hemorrhage syndromes. Okay, so this is a patient with what? Abnormality, right? The lungs, you can't see the vessels. It's almost got a somewhat nodular appearance to it too. So this is all consolidation. It's ill-defined, you can't see the vessels. It is a diffuse consolidation. They have an endotracheal tube. That's pretty helpful too. And you look, this swan is not helpful, by the way. And so when you look at this, this 25-year-old had some congenital heart surgery. You say, well, yeah, that's diffuse consolidation. They've got an endotracheal tube. This most likely represents, diffuse alveolar damage. That's the pathologic term, but people call it ARDS. I don't tend to use that term. And, that's what it is because they have an endotracheal tube. What if I told you the swan measurement was pulmonary capillary wedge pressures was 19? Does that mean this is congestive heart failure? No, this is not. No, it's not. I remember the ICU doctor saying, you can't say that. And I go, well, yeah, I can. I just did. But I'll make a bet with you. I'm betting that his PEEP pressures are high. And they were. The PEEP on the endotracheal tube and the ventilator was 20. So I said, the swan is measuring the PEEP pressures. What you do is you go turn the PEEP down to 10, wait a minute, take another swan, and it'll be normal. And it was. This is another patient, diffuse ground glass consolidation postpartum, shortness of breath. Is this a pulmonary embolus? No, it's not. It's going to be something systemic. It's diffuse. Now, there's no endotracheal tube here, which is kind of important because now I'm not thinking of the so-called diffuse alveolar damage / ARDS, but more along that spectrum of non-cardiogenic edema. Now, non-cardiogenic edema and diffuse alveolar damage are on a spectrum of acute lung injury. In general, non-cardiogenic edema is often not intubated, but they're fairly hypoxic. They'll definitely have oxygen. But in diffuse alveolar damage, it's a profound hypoxia and a profound loss of lung compliance that almost necessitates mechanical ventilation and intubation. So if I see an endotracheal tube, I kind of think more of diffuse alveolar damage. When I don't, I call it non-cardiogenic edema. This patient's got a large consolidation, but it's focal. So therefore, I'm thinking, okay, this is a localized disease process. Acute consolidation, there's some air bronchograms. This most likely represents a bacterial pneumonia. Is it an infarct? Probably not. Why? Well, infarcts aren't very common. I think I talked about that in my last talk on pulmonary embolus, that it's actually not that common. And when you see it, it tends to be very small. Why? Because the lung is kept alive by the bronchial arteries. You can occlude the pulmonary artery, but the lung stays alive because the supply actually is from the bronchial arteries coming off the aorta. So infarcts are actually not that common. Now be careful when you see something like this. This is actually very extensive consolidation. Air bronchograms, vessels are obscured, but it's not diffuse. So you don't kind of go down the non-cardiogenic edema kind of thing. You got to think a little bit more. It's just an extensive disease process, extensive consolidation. In this case, this was a multifocal Pseudomonas pneumonia from a massive aspiration. So if it's not diffuse, call it extensive. But if it's diffuse and it's acute, that can be very helpful. This will limit your differential for etiologies. Now, this is extensive septal thickening. I showed this once. You can see the so-called curly A's and curly B's. I don't use that. I just say septal thickening. It's all part of the same anatomy that undulate from the hilum and that are localized along the pleura. Now, septal lines are best seen on the lateral projection. We teach that you look in the costophrenic angle. To be honest, if you see it, that's great, but there's not a lot of lung there. But if you look in the lateral, right behind the sternum, retrosternum, there is a lot of lung. And so there's a good chance you can see it as this perpendicular sort of 2-centimeter non-branching line extending behind it. Now you can be pretty confident this is a reticular pattern. This is the distribution, in this case is bilateral with associated dependent consolidation. That would be gravitational. And this person's not intubated. This would be congestive heart failure, most likely, right? Hydrostatic edema. Now, edema, a lot of people, I'm going to talk quickly about that a little later, but using the term pulmonary vascular congestion to avoid it. Enlarged or plumped hilum, avoid it. It's not real. People use it a lot. I'll get into it. So this was reticulation. This is a snapshot from Dr. Ito's lab, Japan, where he would take out these lungs and then he would kind of x-ray them. So this is what a secondary pulmonary lobule looks like. This is the septum here. That's the so-called curly B going up to the pleura. And then it kind of connects and then undulates towards the hilum. When those are thickened, that would be the reticulation. Again, best seen on a lateral projection in the retrosternal space. This would be a patient who has lymphangitic spread of tumor, just kind of a nodular appearance to it. But this is your differential. So the hardest thing with reticulation is actually seeing it. But if you see it, it's a short differential. It's hydrostatic pulmonary edema. It's lymphangitic spread of tumor. It's acute eosinophilic pneumonia, which is very uncommon. And that looks just like congestive heart failure. And then there are just a couple of viral infections, hantavirus and stuff, that can give you that septal thickening. Okay. 55-year-old progressive dyspnea. Look, there we go. We have some septal thickening here. There it is. And this one though, it's unilateral. I don't see it on the left. The other thing you notice is the right lung is smaller in volume. Why is that? Well, again, this is to kind of give a shout out that you don't want to be using the term like poor inspiratory effort. You just say low lung volumes. And it's often a reflection of lung compliance. As the lung becomes stiffer, the diaphragm can't descend, right? Because diaphragm is actually not a strong muscle. It's relatively weak. And when things get stiff, it can't descend. So this is a nice example of a less compliant right lung with reticulation. Now, you might look a little closer and you can see, there may be some little bit of nodularity to it. Now, again, I don't like the term reticular nodular, but I tend to say what dominates, in this case, reticulation with some associated nodularity. And in that case, I'm like, it's unilateral. That's probably going to be lymphangitic spread of tumor. And there's the lung cancer is right there. So this would be lymphangitic spread of tumor. Just as an FYI, when you see lymphangitic spread of tumor or pleural metastases, because both are in direct communication. So if you have lymphangitic spread of tumor, you probably may also have pleural metastases or malignant effusion. So those two kind of go together. You can see that here. They kind of go together. So it's usually going to be an adenocarcinoma. Pick the most common for the patient's age and sex as the primary. Mesothelioma, lymphoma, and invasive thymoma. And what's very convenient about this is that this is also the same differential for pericardial tumors and peritoneal tumors. So pleural, peritoneal, and pericardium all have the same sort of serosal microenvironment or growth of these particular tumors. And because in the lungs, the pleura is in direct communication with these septal lines, the interlobular septum, you tend to have also lymphangitic spread of tumor in association. So they all kind of go together there. 34-year-old with a cough. You look at this and you go, well, it's not normal. And you start to look and, well, what's the morphology? Is it reticulation? Kinda. It actually looks kind of curved. These look like commas. And you look then at the distribution, and that's definitely upper lobe. It's perihilar and upper lobe. They're sparing of the lower lobes here. Person did have a biopsy, by the way. But this is actually an upper lobe disease process with curved reticular opacities. Now, what does curved reticular opacities mean? Well, that usually indicates that it's either some sort of cystic disease, or it could mean bronchiectasis. Bronchiectasis tends to be a bit more central, plus or minus fluid levels. Cysts tend to be a little bit more out in the parenchyma. So, but you don't have to really know at this point. You just say this curved reticular opacities per upper lobe, you go to the card. What are the diseases on curved reticular opacities? What are the diseases in the upper lobe distribution? Which one, which diseases are in both? And most likely, it'll be that. Did you need to say that there was an interstitial pattern here? No. Did you need to say there was prominent interstitial? No, doesn't matter. Pathologists tell us both are almost always present. So in that case, you looked into both of those sparing and lung bases. You can see nicely this curved reticular opacity. They just look like commas. And in that case, that was Langerhans cell histiocytosis. This would be an example of commas with fluid levels that are more central. That would indicate more likely that this is severe bronchiectasis. And given the extent of the bronchiectasis, an underlying genetic abnormality is, most likely at some point, or an immune, deficiency. So this is your differential for curved reticular opacities. It's bronchiectasis and cystic diseases. So this is the upper lobe differential, set-part, sarcoid silicosis. Remember, there's two for the first one. These are the most common. Extrinsic allergic alveolitis, also called hypersensitivity pneumonitis, EG/emphysema, right? TB and fungal. Now, TB and fungal I put together because they're both granulomatous reactions that have a great deal of overlap on the imaging. And what I try to say is that when you say TB, at least think fungal. If you think fungal, at least think tuberculosis, because they look so similar. And you can see the rest of the diagnosis here. This is another patient with upper lobe nodular disease. The hilum are pulled up. This is chronic. What gives you nodules? Upper lobe disease. I would think in this case, sarcoid silicosis would be more likely. Is this metastases? No. Why? Metastases don't tend to occur in the upper lobes. Again, upper lobe diseases tend to be lymphatic based, okay, or potentially based on what's the word about pH and some of the other alterations. High oxygen is not actually the crucial element. Okay, by the way, tuberculosis, cavitary tuberculosis, it's based on poor lymphatic flow is the most likely hypothesis. 1983 paper from Goodman and De Perez talked all about it. They went through all of this. The paper was published. We still teach high oxygen. Has nothing to do with it. There's another patient, curved reticular opacities, had a pneumothorax. When you see these cystic diseases, they do tend to kind of spontaneously give pneumothoraces. This patient would be most likely Langerhans cell histiocytosis. Your differential, if you went back here, you notice that PJP is in both as well. So that would be your differential. So you could put your report and say, if the patient has fever or known HIV, then chronic pneumocystis pneumonia would also be a good thing to add in your report. Anything else? No, that's pretty good. It's probably not emphysema. Why? You can see the walls, you can see their cysts, you can see the commas. Okay. 38-year-old with mopsis. When you look at this, you step back and you're like, okay, it's not normal. What's abnormal about it? Well, I'm not sure. There's some reticulation here. Maybe there's nodules. I'm not sure. Maybe some reticulation. It looks like everything's kind of distorted too, so there might be some scarring. Is it bronchiectasis? No, I'm not sure. Okay, well, let's stop at the morphology. I'm having trouble with that. Would it be helpful to say it's an interstitial process? No, it's not going to help you. How about an airspace? No, it's not going to help you. So just leave it out. What about that distribution? What's that distribution? Let's use that. This one is radiating out from the hilum. That's bronchovascular. Let's go with that. Bronchovascular, chronic symptoms, sarcoid, lymphoma, especially Hodgkin's, and Kaposi's sarcoma. Okay. If it's acute, which this is not, you'd think of aspiration, but it'd have to be more gravitational. So it's not that. So we're really kind of coming down to sarcoid, lymphoma, and Kaposi's. And Kaposi's doesn't induce scarring, and lymphoma usually does not either, but sarcoid does. So our, report would say, hey, even though I'm struggling a little bit with the morphology, just based on the fact that there looks like there's architectural distortion and bronchovascular, these radiographic findings are highly suspect for sarcoidosis, period. Another patient, this one's clearer. This has, you can see there's fibrosis. You can see the nodularity, especially the beaded nodules along the minor fissure, the so-called perilymphatic distribution, which we use on CT. Sometimes you can see it on the radiograph. This is sarcoid. I don't really have a differential. You don't need a CT. Okay, I'm going to go through a few pet peeves. Now, you can disagree, but I'm going to be very transparent with it. I'm going to try to explain why. Okay, first of all, infiltrate. I don't know if you use it. I don't know if you do, stop using it. This is an excerpt from the Fleschner Glossary of Terms, and this is the website if you want to download it. Infiltrate is not a good word. It means different things to different people, and it's almost used to describe any abnormality. Again, a report is generated to try to narrow a differential, maybe exclude some things, or give you a diagnosis. When you use vague terms like infiltrate, all you said is, hey, there's an abnormality in the lungs. And it's like, well, good. I can teach my 14-year-old to say that. We'd like to go a little bit better. Just a quick one, lung fields. I don't know if you use that. It just sounds terrible. Fields are for cows. This is from Vermont. Fields are for cows. They call them lungs. They're lobes. You can say hemithorax. I make my residents delete infiltrate and fields from the vocabulary voice recognition thing. Just get rid of it. I don't ever want to see it. Non-specific. We use that far too much. And the problem with non-specific is I'd like to think that we're doing our best to earn our paycheck. And anyone can say non-specific. There are very few things that are specific in medicine. I mean, the book about what we don't know is bigger than the book we do know. But that doesn't mean, we can just, let's non-specific. It's non-specific. Yeah, just, is it abnormal? Yes. Well, what's abnormal about it? Well, there's a nodule there. Well, what about that nodule? Well, it's spiculated. Oh, that's interesting. Any calcification? No. Where is it? It's in the right upper lobe. How old's the patient? 60. Well, I know what I'm thinking. This is a lung cancer until proven otherwise. And, comparison with any priors, if we have it, if we don't, well, this might be a good one to use the CT scan. So instead of saying that, there's a non-specific nodule, you try your best to say, look, I think this is probably what it is, but this is your differential. This is how we can sort it out. Now, pulmonary vascular congestion. I see this used all the time. What is it a radiologist means when they say pulmonary, or a clinician? Clinicians use it all the time too. And to me, this is just right up there with infiltrate. What are you talking about? It's vague. And there are plump hilum, could be pulmonary vascular congestion. What is that? Okay, confusion. What do you mean when you say that? Okay, here in my world, which, I don't know if you want to be there or not, but this is what I'm thinking. Pulmonary vascular congestion really is just one of these vague things like saying prominent interstitial markings. Now, there are different causes that could all be considered pulmonary vascular congestion, and all of them have different therapies. So is it chronic pulmonary venous hypertension with chronic compensated heart failure, so-called cephalization, which does not occur in the acute setting, by the way, that's a myth. It's a chronic process. You do not see cephalization or this plump enlargement of vessels in the acute setting. That does not happen. That is based on a 1971 paper that was falsified from Mount Cedars-Sinai. Okay? We don't use it. That means it's chronic. Is it acute hydrostatic pulmonary edema or congestive heart failure? That's a different therapy. Is it pulmonary artery hypertension? Many times when people say the pulmonary arteries are plump or enlarged or engorged, that doesn't happen in the acute setting. That's actually pulmonary hypertension. Now, it might be from chronic compensated heart failure. It might be from something else. That requires a different therapy, but that's a form of pulmonary vascular congestion. What about renal failure associated edema? That's actually the so-called bat-winged pattern. This whole bat-wing pattern as the classic congestive heart failure is also crap. That is from a 1938 paper in JAMA on a single case report written by an internal medicine doctor on a patient who had renal failure and uremia. And they had developed an edema that looked like perihilar, like a bat wing. That got embraced as the classic manifestation of congestive heart failure, when the classic manifestation is actually this. This, when you see bat wing, you suggest, hey, this looks like renal failure and the patient probably needs dialysis. Different therapy. That's pulmonary vascular congestion. By the way, congestive heart failure, and yeah, you can see how they look very different. Congestive heart failure is like lungs that are towels drying on a clothesline. The water collects inferiorly. In renal failure, it does tend to be more perihilar. What about this patient? This is a patient who's got diffuse ground glass with an endotracheal tube. It's diffuse, it's acute. That, and there's an endotracheal tube. That would be most likely diffuse alveolar damage / ARDS. That requires a different therapy. And then you got the patient here who's got the diffuse I showed earlier, diffuse ground glass, but no endotracheal tube. That's more of the non-cardiogenic edema, that spectrum. It doesn't usually require intubation unless there's pre-existing, cardiopulmonary reserve issues. So these are all examples of pulmonary vascular congestion. I would encourage you not to use that term, but rather, if you think you can, dive in a little bit of what you think it is. Okay, so if I can get a shout out, you're welcome to do what you want, but when I hear pulmonary vascular congestion from a clinician or from a radiologist, Let's keep going, just a couple more. Airspace and interstitial. This one will be a hard one for you to wean off, I'm pretty sure. If you can't, you can't. But I want you to see and really just kind of evaluate. You think it really helped you. Because this is a patient here who's got what's called desquamative interstitial pneumonitis. This is a classic interstitial disease, classic. I put the quotes. But take a look at the alveoli. They're filled with macrophages. There is also interstitial thickening with the macrophages, but this is predominantly filling up the alveoli. So this is actually, when you get to it, both are present, but it's more airspace. So how does that help you? Both are always present, and it leads to vague terminology. I think I've already given you my obstructive pulmonary physiology talk, COPD. I'm going to encourage you not to use it for the reasons I said there, because it leads to algorithmic treatment. Use something like obstructive pulmonary physiology, because when you say COPD, you ignore two very, very important and two very common pathologies, tracheobronchiomalacia and constrictive bronchiolitis. Both require different therapy, and the therapy used with steroids and COPD actually harms these people significantly. Wide mediastinum, don't use it. And I'm going to go through that specifically. It's outdated, and you cause a great deal of clinical anxiety when you say it. Wide mediastinum, don't use it. Lastly, this is a pet peeve. And if you can't wean yourself off it, that's fine. Don't worry about it. My residents were never allowed to say any of these, by the way. Clinical correlation, no. If clinically indicated, no. It can look like anything. Okay, when you say it can look like anything, you're not teaching, right? You're not teaching. You've just given that resident or that person permission to not dive in and try to learn more about this, because they'll just take that information and go, good, I got too much to learn already. TB, I can look like anything. Sarcoid, it'll look like anything. Lymphoma, I can look like anything. That's not helpful. So again, I love the word if in my reports, and I'll talk about it with the high res. If the patient symptoms persist, consider this. By using the word if, you're not handcuffing the clinician to order something. But if the symptoms are persisting, there's likely a diagnosis that we're missing. And this would be the appropriate person in which to dive in and kind of look a little bit closer. All right. So I'll give you an example of my pet peeves. These are actual reports. I'm not, and this is what I'm talking about with the rut that we get into. We just you just start saying the same things, and it's not really soul filling. There are prominent non-specific interstitial infiltrates with pulmonary vascular congestion, clinical correlation recommended. That is garbage, total garbage. My report was bilateral moderate peripheral reticular opacities consistent with pulmonary fibrosis, suspect concurrent pulmonary hypertension. That's what's going on. That was the pulmonary vascular congestion, was pulmonary hypertension, and the non-specific infiltrates are actually reticulation that is most likely pulmonary fibrosis, which is inducing this. This requires a pulmonary involvement. Findings consistent with COPD. Boom. Boy, was that helpful. Got the treatment. It wasn't emphysema. Patient did lose their insurance here in America because they said they didn't smoke and were told they lied. Mine was obstructive pulmonary physiology secondary to tracheobronchial malacia. Trial of BiPAP is recommended, period. See, it doesn't take as much effort as you think. It's how we organize this and what we feel that when we sign our reports. Engorged, and I've also seen plump, vessels consistent with pulmonary vascular congestion. No. Findings consistent with chronic pulmonary venous hypertension, or if you prefer, this is a nice term, chronic compensated heart failure. They don't have acute hydrostatic edema radiographically, but they got findings that tell us that their left ventricle output is chronically low. And associated pulmonary hypertension, no acute hydrostatic edema. Okay, again, see what you're comfortable with. But when I was a resident, these were the reports that my faculty wanted me to say. And I would have to sit there because I'm older. I had paper. I had to sign these once they came through, and I would look at them and I would feel embarrassed. I would. I didn't know then what else to say, but I just knew I did not like these reports. All right. We're going to finish with a couple of things here. We'll take a look. So the couple are the hilum and the wide mediastinum. And here we go. The hilum, and the reason I'm doing this is because I work with some great radiologists, and I found that they struggled with this on radiographs, like really did. And again, I think it comes back to our curriculum and our teaching. But the hilum on the PA or AP has a lot of different variability. And so it can be really tough. To me, the density is more helpful. They should be the same density, right? Same density. So, but I find the lateral projection is really helpful. That's where you can really tell hilar adenopathy. So let me show you why. The left distal main bronchus comes out. Left distal main bronchus is seen as a hole of air. Okay. The right pulmonary artery comes up and then goes at a right angle. So on lateral, that's seen on in, and it's got blood, so it's white. And they are on opposite sides, but they overlap on the radiograph. So the left distal main bronchus is in the back, and then the right pulmonary artery. So air and then white. That's it. That's all what you should see for a normal hilum. Now, wow. What happens when that whiteness of the right pulmonary artery is all around that left distal main bronchus? Well, that's kind of called the donut sign. And the donut sign is a sign of hilar adenopathy. And it's so much easier to tell on that lateral projection than the PA. Left distal main bronchus, right pulmonary artery. Nothing else, normal. Right, left distal main bronchus, right pulmonary artery. Oh, snap. Right, adenopathy. Try it out. Take it out for a spin. It's really, you can tell. So you just got to look for that left distal main bronchus, which you see about 95, 96% of the time. Okay. Remember, also the retrosternal is a good place to look for septal lines, and pleural effusions would be down low here. This is the basement of the pleura, and any effusion will be seen here first before it'll be seen on the AP or lateral in the costophrenic angle. So these are the three areas that I would suggest you look at with your lateral to find these. Okay. And this is the last one, and I call this eminence-based medicine. Your eminence taught you, you grow up, you teach the same thing, and on we go. We're all think alike, no one thinks very much kind of phenomenon. It's very common. We got a lot to learn. It's, you know, you can't question everything, but after a number of years, you start to notice things. Caution, the sign has sharp edges. Do not touch it. Is that wrong? No, that's not completely wrong, but it's not really that helpful. Patient has pulmonary vascular congestion. Great. Also, the bridge is out ahead. More relevant, harder to find, harder to learn. The wide mediastinum. The dogma is a wide mediastinum, especially with trauma, indicates possible hematoma, which may be secondary to great vessel injury. What about this? A wide mediastinum on a radiograph is actually a good prognosis. Why did I say that? Because on its own, the wide mediastinum is not concerning. The mediastinal width really is determined by the intravascular fluid volume status, rotation to the right, and tortuous aorta / big body habitus. Okay? Mediastinal density and contour. That's what's important. That's what's important, not the width. Okay, this is the same patient, pre and post dialysis. Pre-dialysis, look at the superior vena cava, look at the right atrium. Post-dialysis, what happened to the mediastinal width? It got less. So now I go back to you, patient in a severe trauma. You take a radiograph and the radiograph looks like this. That's actually not a great prognosis, but the radiograph looks like this. That's a better prognosis. These people have an 18 gauge or 19 or whatever it is, and normal saline coming flowing in, they're supine. You better see that superior vena cava distended, because if it's not, where's it going? Well, they're bleeding out probably. Okay. When this is the same person, we just took them, rotated them 15 degrees, rotated to the right, and you can tell by the clavicle, right? The right clavicle is farther from the spinous process. Look what happens to the superior vena cava. That's up front, the descending aortas and back. Once you rotate to the right, you just widen the mediastinum. And when you rotate to the left, well, you narrowed the mediastinum. So wide mediastinum, usually right-sided. Now, this is a paper coming from Harborview in Seattle. It's a very good paper. 6 blinded radiologists evaluate 30 trauma radiographs with aortic injury, 47 randomly selected, okay? Overall impression. So the only thing they had to do was just look at it and you gestalt it. And then the second category is the mediastinum wide. That's it, yes or no, is the mediastinum wide. Turns out that their sensitivity and specificity was worse than with wide mediastinum. Like, they don't know what wide mediastinum is, but their overall impression actually did better. Both weren't very good, by the way. And I love their conclusions. Medical education has ingrained the widely promoted concept of mediastinum widening, which is misleading. We believe this term causes confusion and should be discontinued. Oh man, I concur. So what is the definition of a wide mediastinum? Anybody know? I mean, I got taught, well, you look at 1,000 of them, you'll know. And it's like, what if I'm looking at 1,000 of them wrong?
Honey.
Yeah. So beeper sign is one that was used a lot when I was a resident. The surgeon would come up to the radio, put their beeper, and if it was wider than the beeper, they would say, you know, continue on. And I just went, man, that's not science. It turns out from 1976, Marsh concluded that 8 centimeters was wide. And that was in 1976. What's changed since 1976? A lot. I can tell you in America, the body habitus has changed quite a bit. Second, the film screen used to be a narrow latitude. So the mediastinum was a white blob and the lungs were black. So you used contour and width. The other thing is that they used to barrel roll the patients up when they did the study, put the cassette underneath them. Well, now we put it in a trauma table, so you've increased the patient to screen distance, effectively magnifying the mediastinum. So basically, everything's changed. And because of the wider latitude used with the digitals, you can actually see the differences in density in the mediastinum. So there's your aortic arch. This is your standard of reference. The aortic arch will be wider because, remember, density is also based on thickness. And the aortic arch is horizontal, so will stop more of the beams than the superior vena cava, which is vertical and has fat and air on both sides. So therefore, this should be less dense than this. That's it. This is too dense. You can see it's lobulated. I don't care if the mediastinum's wide. It's too lobulated. I can't see the arch. This is a trauma. This was blood, and the blood got into the other side, stopped the beam. So when the right side of the paratracheal is the same density or greater than the arch, that requires an explanation, and large lymph nodes could do it. How about this patient? This is a patient who can't see the arch at all. This density is not bad, but there's a huge amount of mass effect, and it's way too dense here. This is actually a contained rupture. How about this patient? Contusions, chest tubes, multiple rib fractures, too dense, can't see the arch. This was an aortic transection with a large hematoma. What about this patient? Narrow mediastinum. Well, that's not so good. And you know what? This is too dense. Turns out this is actually mediastinal blood, and they had active bleeding in the abdomen. They didn't make it. What about this patient? No trauma. The contour is not flat, it's convex. Can't see the arch. That's adenopathy. And you can do a lateral here to confirm the hilar adenopathy with the donut sign. So 3 patients with an MVA. There you go, people. Which one has a hematoma? Which one is going to be positive? And what 2 are negative? All of them got scanned, by the way, because the mediastinum was wide. So it turns out the big one is this one. This is the one that's got the blood. This density is less than the arch. There's your azygous vein. That's less dense. That's rotated to the right. This is less dense than the arch. There's your azygous vein. That's normal, no mass effect. There's mass effect on the trachea. This is too dense compared to the arch. That one needs an explanation, and that was a bleed. That's it. So wide mediastinum, practical points, use the density, use the contour. Look for mass effect. A wide mediastinum on its own is not important. It's not important, and it causes unnecessary concern and a lot of ordering of tests. Okay, finish with this. Education is the progression from a cocky ignorance to a miserable uncertainty. That's right. Yep, Mark Twain. Yep. Here's your summary case. 44-year-old, chronic cough, no fever. What do you see? It's not normal. Seeing some areas of ill-defined opacification, air bronchograms, peripheral, maybe a slightly upper, peripheral consolidation. It's chronic. Chronic. What's the other thing you see? Look at the mediastinum. Wait a minute. That's too dense. Hold it. That's convex, and that's too dense. The hilum look really dense. Shoot, I think this person has adenopathy. What's the most likely diagnosis? You would look in the chronic consolidative differential. Mucinous secreting adenocarcinoma, COP, multifocal hemorrhage, alveolar sarcoid. Which one? Well, when you look at it, I've got a little hint on there. If you see a lot of adenopathy in the setting of chronic consolidation, it's going to be lymphoma or it's going to be a granulomatous process. In this patient, it was alveolar sarcoid. Is that interstitial? About 90% of alveolar sarcoid is interstitial, but it has an airspace component, and people would traditionally say, oh, that's an airspace process. Again, highlighting that that doesn't help you, but it did help you to say that's a consolidative process. So I'll look in chronic consolidation and there's adenopathy. This is probably alveolar sarcoid. So with that, I will stop. Albert Einstein said, because I'm not a fan of algorithms, by the way, he who joyfully marches to music and rank and file has already earned my contempt. They have been given a large brain by mistake, since for them, the algorithmic spinal cord would be sufficient. All right. So that being done, I will stop there. Take a moment to catch your breath. And if you want, I can send you the talk. Feel free to use it. Look at it. Take the card out for a spin. See if that helps you get out of that rut. Maybe try to make some better reports. that you can feel pretty proud about. I'll tell you, if you do, you got to skip in your step when you go home. All right.
Thank you very much, Dr. Gosselin. This was an excellent lecture, and it's really like even very, very beneficial for us residents. We tend to rush to CT and we tend to forget how much a normal chest X-ray can tell us. So thank you for this very eye-opening lecture, and it was really beneficial. Thank you very much.
My pleasure. It's my pleasure sharing it, man.
Thank
It's
you.
good stuff. It works really well. It does work well. My residents have done well out there in the world, in this area.
Thank you so much, Dr. Marc, for this amazing lecture. We hope to meet again in another session in the future.
Well, I got one right now.
Okay, thank you. So much.
I got
Thank
two.
For the next one, sure.
Thank you. Thank you. Thank you.
I got two. You're not done with me.
Yeah.
Oh no.
Just giving you a few moments to catch your breath just between the two lectures. Yeah.
Thank
Please
you.
catch your breath. This
Yeah.
is but this one won't be quite as difficult for you because we're going to build upon what I just talked about and we're going to apply it to the CT.
Very great.
How do I share the screen on this one?
I think your old screen is still shared. Can you just maybe?
Oh, is it
stop
still
the
shared
work?
right now? If it's still shared, that's great. Is it? Can you
Yeah,
see
you
this?
can still share a new screen if you want to share the new lecture.
Can you see this?
It's not working with me. Just
I think so. You must be able to see it, I guess.
it's not working on my. Can someone else confirm if you can see the screen, please? It's not sharing.
Oh,
So
it's not. All right. How do I get you to see this one now?
I think there's in the share screen button, you can choose which tab you want to open.
Okay.
You may be sharing the old one right now. Maybe you can just share screen and choose the new one, the new presentation.
Can you please stop sharing and reshare it again, please?
Stop share. Oh, got it. I got it. I see what you mean. Thank you. Now you should be able to see it.
Yeah.
All right. Thank you so much for that. Sorry. You know, for a radiologist, I'm technically terrible.
Okay.
You young whippersnappers are much better at that stuff than me.
We're still learning from you.
All right. Yeah, let me know when you're ready, but we're going to apply the card and we're just going to build upon the same things and all of that terminology and all of that stuff I've talked about in the radiograph. All of it is equally applicable to the CT. It's exactly the same. Except we can just see things a little better.
Yeah. You can start whenever you if you're ready.
All right. Perfect. No disclosures. Okay, so this we're going to try something a little different here. Now, you probably have seen a number of, diffuse lung disease or ILD, kind of deals. This one's going to be a little different. I tried to make it very practical. When you sit down and you're looking at a view screen and this pops up, you're like, God, they made it look so easy. I don't know what to say. We're gonna try something. We're gonna do it case-based, but we're gonna look at this from the point of view of what is your report impression gonna be. And when you get really down to it, there are 5 major categories of impression. So you'll kind of figure out where in those 5 you will be. We're gonna also, again, look at morphology, distribution. We're gonna use the card. And I'm going to help you, hopefully, with your thought process. The pulmonary lung diseases are extremely confusing, mostly because the terminology doesn't make a lot of sense. And it gets confusing. The other thing that's confusing is how we mix pathology and etiology together. Now, I'm going to be very specific when I talk about this. By separating those, your thought process and your reports will look so much clearer and be so much more understandable. So here we go. Assess for ILD. You're sitting there and you look and you go, oh no, it's ground glass. Oh, great. I love ground glass, by the way. It's all in how we organize it. What's your report going to say? See, that's what I'm telling about. It's hard. This is difficult. Let's start off with what normal is. And this is me, by the way. I scanned myself. I scanned my whole body. So, you know, if you don't look like me, there's something wrong with you. So this is what the lungs should look like. They should be vessels branching. The vessel artery, pulmonary artery, and the bronchus should be right next to one another and the same size. The pleura, look closely at the pleura. It should be smooth, very smooth. When you start seeing a little serrated knife or pie crust kind of triangles, that tells you there's underlying scarring and fibrosis. Okay. When you take a breath out, the lungs should get more dense, more opaque as it goes dependently. That's because there's less air per pixel, right? Less air per pixel in that particular area, so it'll be whiter. This is what you should normally see in expiration. So if you don't see that, that needs an explanation, okay? All right, so smooth borders, smooth fissures. Expiration, the other thing you should see, the airway should stay open. In inspiration, the trachea will be round. In expiration, it will be flattened posteriorly. Okay. All right, that's a little normal. Common morphology. Here are what you will tend to see. There's increased opacity, which is consolidation or ground glass. There's decreased, that's emphysema, cysts, mosaic lung attenuation, which I didn't talk too much about mosaic lung attenuation in the last talk. I will here. Reticulation, same differential as what we talked about. Nodules, are they random, perilymphatic, or centrilobular? Now, the reason this is important is because now there's a new distribution. So the distribution is based on the secondary pulmonary lobule. Is it within the secondary pulmonary lobule, mainly centrilobular, or is it along the septum, the pleura, and the bronchi? That would be perilymphatic, or is it just both in all of them? Well, that's random. And that changes your differential substantially. And lastly is airway. Okay, the airways, the tracheal abnormalities, tracheal bronchiomalacia, the bronchiectasis, bronchial isobliterans, and small airway patterns, which often manifest with a mosaic lung attenuation. So the distribution, it's the same as the radiograph, with the exception relative to the secondary pulmonary lobule. And this is your secondary pulmonary lobule. Okay, is it predominantly central? Is it along the edges, along the septum, or is it both? That's the only difference. Otherwise, it's the exact same thing as the radiograph. There's your card. This works really well on the CT too. Now, why is this so confusing? I attended a lecture. Here's the slide. I walked out of the lecture. It doesn't make any sense. The reason you can't remember these things is it doesn't make any sense. I want you to take a look at this. Just take a look at it. By the way, that thing that UIP or IPF is the most common idiopathic, that's not true. It's actually sarcoid. But this was written by a pulmonologist. So it doesn't make any sense because pathology and etiology are completely mixed together. Everything is mixed together. When you watch a lecture and the lecture is, say, vaping related pneumonitis or infections or something of those like, these tend not to be useful. And the reason is because you're giving a lecture based on an etiology. And any etiology can have different pathologic because people are like snowflakes. If we all took amiodarone, what would be our pathology result? It would be varied. So you will hear these talks like vaping-related pneumonitis. Well, it could be COP, could be diffuse alveolar damage, could be acute eosinophilic pneumonia, could be normal. And so you're left with what? Well, it can look like anything. So it's non-specific. God, chest radiology are long differentials. These are given by very high-profile people too. Yet it doesn't make sense. You need to hear this from the pathology point of view. We, as radiologists, look at the morphology and we look at the distribution. We try to determine, to the best of our ability, what is the most likely pathology that is going on. This is the most important thing that we can offer because it determines prognosis and it determines treatment options. Pathology is not the same as etiology. Let me explain. Etiology has, with one etiology, there are multiple different pathologies and they all overlap because the lung, like the brain or like the bone or like the GI tract, only has certain ways to react to injury. And it's determined, it's different for all of us genetically. It's just different. So don't look at it that way. It's the pathology that matters. We can help with the etiology. Like when you have, in my last talk, you have diffuse ground glass. Well, the pathology is most likely non-cardiogenic edema or diffuse alveolar damage. The etiology, because it's diffuse, will come from outside, so we should consider sepsis or TRALI. Those are the etiologies. But the most important thing is it non-cardiogenic edema? That's the pathology. Okay, so here's an example. This patient has reticulation when a bronchovascular distribution, subpleural sparing, most characteristic for fibrotic NSIP, which I don't like that term because it has the word non-specific in it, which I've already told you I don't like it, but I can't change that because that's what the pathologists have called it, but it actually has very specific histologic characteristics. This is considered most consistent with fibrotic NSIP pathology. That's the most important thing to diagnose. That has a prognosis and a treatment option. Drug toxicity or autoimmune diseases are possible etiologies, period. I separated them. When you go to a talk and say, we're going to talk about drug toxicity, so you're getting the talk based on the etiology, and guess what? The pathologies are going to be all different. They're going to be a whole bunch. You're going to leave the talk, God, drug toxicity can look like anything. These are pathologies. This is what we need to try to diagnose, or at least help with the diagnosis. Is a consolidated organizing pneumonia. And by organizing pneumonia, I just mean it's a consolidated process, essentially. It can be infectious. It may not be infectious. It may be acute. It may be secondary to bacterium. It may not be. It's an organizing pneumonia. That's what the pathologists call it. What is your differential of possible etiologies for organized pneumonia that you can help? But based on just diagnosing organized pneumonia, that is really helpful. That's a good prognosis. And if it's not bacterial or infectious, it tends to respond well to steroids. Okay. Other things, sarcoid, that's actually a pathology. We don't know the etiology. That's why it's idiopathic. Hypersensitivity pneumonitis, there's two types. Did you breathe it in or is it in the blood? And they look different. Okay. This is what we want to try to diagnose. These are etiologies. And they get mixed up all the time. Oh, well, you never know. I think this patient has a drug toxicity. Okay. Great. Is it UIP, which is not good? Is it fibrotic NSIP, which is less not good, but is it COP, which is fine? See, the prognosis is based on pathology. I've seen reports that say, oh, this could be hypersensitivity pneumonitis, drug toxicity, autoimmune disease, UIP, pulmonary fibrosis, blah, 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 blah. And that's it. That's the differential. And what's wrong with that is it shows that the radiologist was confused, doesn't understand how to separate it, and therefore on the report impression, it shows that they don't know how to separate these things. Okay, so let's talk about the report impression. You're sitting down at your next day on the chest service, and you got a CT scan looking at some diffuse abnormality in the lung. Here's your 5 important impressions, 5 generalized. I mean, there's exceptions. The imaging is normal. Cool. I love those. Those are great. They're quick too. Imaging findings are questionable, uncertain, like I hate these. Why? Well, it's normal or it's abnormal. And you think that's not common? It's common. And we don't sound very intelligent when we say that, but the reality is you're going to encounter these where you look at something and you're like, I don't think it's normal, but I'm not sure it's abnormal either. And I'll teach you how to sort that out so you don't have to say, I don't know. There are things that you can do. And the big one, if you want to know, is a pulmonary function test called the DLCO. DLCO. That will bail you out almost all the time. Imaging findings are characteristic for this diagnosis. I love those too, because you can come down hard on it. There you go. This one's not bad either. It's abnormal, and it's a short differential that clinical history or laboratory tests can help sort out. And of course, we wouldn't say clinical correlation or if clinically indicated, because we don't say that. We use the word if. And you can also use the word pulmonary, or a term pulmonary consultation, for further workup and treatment options is recommended. That works too. It's a short differential. And then the last one, which unfortunately is still very common, the diagnosis, I have no idea. It's clearly abnormal, but I don't know what it is. And that one still happens, so don't worry about it. And all we do is, rather than say it's non-specific, clinical correlation, that sort of crap, try to say, well, if the patient's symptoms persist or something, pulmonary consultation or thoracic surgery consultation for open lung biopsy, sputum analysis, there's all sorts of things that we can use to try to get to the bottom of it. All right, this would be an example of how I would do a report, and you can see what you think. See if you can see the subtlety in which I'm talking about. There's moderately advanced pulmonary fibrosis. Why? I see irregular visceral pleura, I see reticulation, traction bronchialexis, a little bit of subpleural sparing, bronchovascular distribution. That is most likely fibrotic NSIP pathology. UIP is possible, but I think it's less likely. Consider autoimmune or drug toxicity as possible etiologies. Tissue sampling is recommended, and I would do a VATS procedure, a thoracoscopic biopsy, because bronch would not help here. That's my report. I separate the pathology. That's the most important. Here's some possible etiologies. This is what I would do. Okay, this is kind of, I'm from Portland, Oregon. So throwing some pictures for you. All right, this is the hardest one. Are the findings that you see, are they real, or are they just normal or normal variant? And unfortunately, this is common. And the big one I find is with ground glass, central lobular ground glass nodules, and small airways disease. The other one that a lot of people talk about is dependent atelectasis versus pulmonary fibrosis. Most people just say, oh, you should do a prone, But I think you can tell without, because dependent atelectasis should just be that. It's dependent. If you start seeing it going up laterally, that's not just dependent atelectasis, that's fibrosis. And also, atelectasis does not give you an irregular visceral pleura. So if you see what looks like dependent atelectasis and you see the pleura is irregular, that's fibrosis. So you can do your prone if you want, but it'll be there. So, but let's focus on this. These are the tough ones. Here you go. CT pulmonary angio, 49-year-old female, worsening dyspnea. They get a CT for pulmonary embolus. Of course, there's no embolus. And so you look at this, and now, do you think that this is abnormal ground glass? Or do you think it's partial expiration? Because look, the trachea and the bronchi, it's straightened. So this is partially expiration. Is this ground glass? Or is this just partial expiration? Now you got to think about it. That's hard. So let's go back to what we learned. This is me again. Look at what happens when you take an expiration. The density gets higher as you go posterior, dependently. Let's look here. I'm not really seeing it. I'm not really seeing it. And I'm also seeing these areas of mosaicism of air trapping. I think this person has a ground glass process. I think this is what the person's problem is. It's just really subtle and it's hard. How sure am I? Well, maybe 90%. But how would you do your report? So instead of saying it's nonspecific, can't tell, you'd say, hey, the findings are suspicious for a diffuse ground glass process, although this isn't partial expiration, suggest further evaluation with pulmonary consultation and DLCO measurement. The DLCO, if it's normal, we would just say, well, wow, that was just expiration. But if the DLCO comes back and it's low, you made a great find. This was a very subtle diffuse lung disease that now can be addressed. So the DLCO is a good way to sort of work your way out of this. That was DIP, by the way. So what about this? You'd see this patient, but are these real? Little centrilobular ground glass smudgy nodularity. It's pretty subtle, but yeah, I think they're real. That's a lot of them. We shouldn't see that much. Look at the pleura. The pleura is smooth, fissure's smooth, there's no fibrosis, but there's these little centrilobular smudgy nodules. The patient is a heavy smoker. And in this case, you'd say, hey, you know what? I think this is DIP or RBILD, which is on a spectrum of DIP. Those are pathologies. Most likely etiology, smoking. Suggest pulmonary consultation for, well, of course, what the problem is they got to quit smoking. So take a break for a moment. This is a fun little paper that was done in the Canadian Medical Journal a number of years back around Christmas time. So they named it Noel's, French for Christmas. 100 attendees over the presentation, nodding off events per lecture. And the longer the lecture, this one will be long, risk of nodding off. And here are the risk factors. My favorite is if the person has a monotone voice, or this one's fun, the presenter's wearing a tweed jacket, there's a good chance you're going to fall asleep. Okay, so imaging findings are characteristic or a short differential. These two are wonderful, up there with normal. You look at it, based on the morphology, based on the distribution, what the pathology is, you give a possible etiology. It's a short differential for the pathology, and just and if the patient's a smoker, this is what it is. If not, it's this, kind of a short differential. Again, use the word if rather than clinical correlation or clinically indicated. Okay, take a look. 65-year-old, progressive shortness of breath. You're sitting down. Here's your exam. All right, it's abnormal, right? What's abnormal about it? What's the morphology? Well, I'm seeing some reticulations here. These are the so-called septal lines, right? Don't see it over here. There's also thickening and irregularity, maybe a little associated nodularity along the fissure. These septi also seem to have a little bit of nodularity. And then, of course, there's a mass right here. What is this? Yeah, and why is the lung volume decreased on the right? What was the reason again? There's poor lung compliance. The diaphragm and the lung cannot expand, and so it looks smaller. Again, that's why we don't say poor inspiratory effort. It's lack of compliance. This is a patient with lymphangitic spread of tumor. What's your differential? None. What is the histology of this lymphangitic spread of tumor? It's lung cancer, because there it is right there. What's the histology? Which histology gives you lymphangitic spread of tumor, pleural metastases, pericardial metastases, and peritoneal metastases? Adenocarcinoma. Thank you, Noah. It's adenocarcinoma. Boom. Now squamous cell doesn't. Squamous cell doesn't do this. See, this is fun stuff, don't you think? You can really come down hard on this stuff. So lymphangitic spread of tumor, interlobular septal thickening, right? That's the same differential as the reticulation. It's the same differential as what we used. So this is congestive heart failure. Notice the septal thickening. Doesn't really have that nodularity, but that's it. And it's got some trace effusions. That's a nice key component. Just as an FYI, remember I told you that tuberculosis does not occur, a cavitary tuberculosis does not occur in the upper lobes because of high oxygen. No, it doesn't. It's poor lymphatic flow. These septal lines represent lymphatic flow. They're like sump pumps for water. Notice where they are localized anteriorly. As you go up in the lung, you will notice you will not see septal lines in the superior segment of the lower lobe, posterior segment of the upper lobe, or the posterior apex. That is because there's very little lymphatic flow, and that is where tuberculosis, which is an indolent infection, tends to grow and cavitate because it's not being cleared. That's the most likely hypothesis why tuberculosis occurs in those areas, along with chronic other diseases like chronic hypersensitivity pneumonitis, histoplasmosis, sarcoid, cystic fibrosis. When you look at them, you will notice most of the time they are upper lobe and posterior because there is not a lot of lymphatic flow as opposed to anteriorly. Okay, 28-year-old female, chronic cough. You look at this. All right, it's not normal, is it? Wow, no, it's not. What's the morphology of this? Well, it's ill-defined, and I can't see the vessels, so that's consolidation. And there is some ground glass. There's a lot of architectural distortion, though, right? Look at the airways; they're being, bent around and pulled apart. So this most likely is a chronic process. So chronic consolidation. This most likely represents what for a pathology? This is a chronic organizing pneumonia, most likely. What's your differential? That's the pathology, and that gives us an idea about the prognosis, that this will probably be steroid responsive, assuming it's not infectious. Probably not. What are some possible etiologies? Well, you can name the common ones. Could be drug toxicity, could be autoimmune disease. It could be cryptogenic organizing pneumonia. If they're a BMT patient, graft versus host disease. Remember, graft versus host disease is an etiology, not a pathology. Okay. So in that case, it was COP, cryptogenic organizing pneumonia, but all of those other etiologies could manifest. But what was most important is you diagnose this as a chronic organizing pneumonia, and that gives the clinician the prognosis and the therapeutic options just to make sure they rule out infection first. So this is your differential of chronic consolidation, just like the plain films. And if there's adenopathy, it's lymphoma or sarcoid, granulomatous. So cryptogenic organizing pneumonia, various etiologies can induce the same pathology. Okay, that's why you don't mix in those. What's important is that was an organizing pneumonia. When you see airways pulled apart, that's a pretty good sign that it's probably going to be chronic. Probably going to be chronic. Okay. All right. Very good. What about this one? 59-year-old, worsening productive cough, dyspnea over 3 months. You look at this and you go, it's abnormal. What do you see here? Well, I'm seeing consolidation again. I'm seeing traction bronchiectasis. There's some fibrosis here. There might be a little nodularity. I'm not sure about that one. That's, yeah, probably some nodules. What about the distribution? Anybody see a distribution here that could be really helpful? Anybody see a distribution that could be helpful? Bronchovascular, beautiful. Get the card out. Chronic consolidation, bronchovascular. And then you go look at this and you're like, okay, this is an organized pneumonia. It's bronchovascular. Well, you know, that could be an infection. It could be sarcoid. I get lymphoma. Boy, I haven't seen lymphoma look that way, but oh, wait a minute. Lymphoma's in the chronic consolidation. Lymphoma's in bronchovascular. So it could be lymphoma too. They didn't really get treated too much with steroids, just antibiotics, and it progressed. They went on to open lung biopsy, and it was pulmonary lymphoma. Again, that bronchovascular distribution, I mean, this almost looks like a spider, an arachnoid sign, right? That's really helpful. It's helpful in that you can come down a little bit harder on these particular diagnoses. So what organized pneumonia has a lot of etiologies, but when you see that bronchovascular distribution, the etiologies got really small. It's basically sarcoid, lymphoma, maybe Capichase. There you go. All right, this is near where I live. Okay, ground glass. Most people don't like it. I'm going to give you a little hint. This is a lot more fun. Ground glass, especially acute, it's actually blood, pus, or water. The harder thing is seeing. Now, how can you see it? One is that you might notice almost slight mosaicism, but when you look, the vessels are all the same size, so that would indicate most likely ground glass. The second thing you want to look at is the bronchi. The bronchi should be the same density. Look, the same density as the parenchyma. Here, the bronchi are lower density, and they stand out. That is called the dark bronchi sign, and it's really just an early air bronchogram. Okay, that's all. So this is the dark bronchi sign. This is ground glass. Maybe there's a little crazy paving, but it's mostly ground glass. And it's got an upper lobe distribution. This was pneumocystis. Again, acute ground glass. Look in the upper lobe distribution. There it is. Pneumocystis. Your key on the CT, when you see ground glass and it's acute, this is acute now, blood, pus, or water, look for pleural fluid, even a little bit of pleural fluid. If there are pleural effusions, I call this the wet disease. This is not in books. Okay, nobody teaches this. Wet disease it is a leaky system, and that's going to indicate edema. Now, the edema might be hydrostatic edema, congestive heart failure, septal lines, lower lobes, dependent, or non-cardiogenic edema / diffuse alveolar damage, more diffuse usually. Pleural effusions are often seen in those settings because it's a leaky system. Now, if there are no pleural effusions, you think of the dry diseases, pneumocystis, CMV infection, acute hypersensitivity pneumonitis, pulmonary hemorrhage syndromes. Pulmonary hemorrhage syndromes usually don't have any pleural fluid. So your differential would shift. This is a patient with ground glass, no pleural fluid. Patient with ground glass, septal lines, pleural effusion. This is hydrostatic edema. This one you would say, well, maybe it's a pulmonary hemorrhage syndrome. Maybe it's COVID, because COVID would be the same as CMV or pneumocystis. Is this congestive heart failure or non-cardiogenic edema? Probably not. Probably not. There's no fluid. So this actually did turn out to be pneumocystis, not pneumocystis, CMV. How about this one? Extensive amount of ground glass, some consolidation, maybe a little crazy paving. You can see the emphysema here. Why do you see emphysema? Because remember, emphysema represent balloons. Nothing gets in, nothing gets out. Any pleural fluid? None. First differential, I would consider a pulmonary hemorrhage syndrome. But those are rare. I know they're rare. But this is what they look like. They don't tend to have pleural fluid. And it turned out, yes, this patient had anti-glomerular membranes, or the so-called Goodpasture's pulmonary hemorrhage syndrome. Okay. All right. That's where I grew up, in the Adirondacks of upstate New York, near Canada. So this is a patient who I showed this histology before, why airspace and interstitial really doesn't matter. This is a patient with DIP. How do you know? Heavy smoker, ground glass. There's a little bit of emphysema. Nothing gets in, nothing gets out. That's why it looks black. Look at the pleura, though. This pleura's got a little bit of irregularity. When you have fibrosis, it retracts and scars down, right? So the pleura will come in like this and look like a little serrated knife. When you see that serrated knife appearance, or that pie crust appearance, that tells you that the lung underlying it is scarring down. And so we start thinking about these fibrotic lung diseases. Okay, this is DIP. The key here is the degree of fibrosis. That's how you're going to approach these chronic ground glass processes. Most radiologists can't stand chronic ground glass. I want you to say, hey, it's just because you're not approaching it right. We're looking for pathology, and we understand that the degree of fibrosis is really helpful here. And you don't have to memorize this stuff. It's on the card. You know, just work on the perceptual skills of seeing this. Eventually, if you use the card a lot, you'll just know it. So is there no fibrosis that you're seeing on the imaging? There might be some fibrosis histologically, but it's not very severe. Then these are your most likely pathologies. Keeping in mind, RBILD, DIP, they represent the same thing. They are seen in smokers. Hypersensitivity pneumonitis. Guess what? That's seen in non-smokers. These two look a lot alike. If the patient smokes, it's that. If they don't, it's that. Next, follicular bronchiolitis, LIP. This looks similar too, but this is seen almost exclusively in autoimmune diseases or HIV. These other ones look very different. So moderate to severe fibrosis, moderate to severe fibrosis. You know what? It's UIP, which a lot of people call IPF. That's usual interstitial pneumonitis. Again, so sorry, these names are terrible. And if it's helpful to you, if even this is confusing, think of it this way. UIP, usual interstitial pneumonitis. You know what? That is all by itself. Every other one of these is inflammatory driven. And the treatment is similar, although the prognosis is a little different. But UIP is not really inflammatory driven. It does not respond to steroids at all. It requires a different therapy. And it looks different than the others. So UIP is different. All the others are inflammatory driven. So even if you're not sure, just try to say, okay, is this UIP or is this one of those other ones that I can never remember? Here are the 4 imaging findings of fibrosis. Again, I'm hitting this hard because you will see these chronic ground glass problems. And the key here is how much fibrosis is present. So you have to know what you're looking for. 1, is the visceral pleura irregular and serrated? Yes, that's a good sign, right? This is clearly irregular. Do they have short reticular opacities that kind of crisscross? Reticular, again, meaning lines that don't branch, but these crisscross. Yes, that's a pretty good sign of fibrosis. Is there traction bronchiectasis or bronchiolectasis? That means that the airways are being pulled apart that it's not bronchiectasis that's intrinsically an airway problem. That's just bronchi living in a really bad neighborhood, right? And everything is scarring and the airways are being pulled apart. Okay. The last one is their honeycombing. And I'm going to tell you that is really hard. That one is the most difficult of all of these to find. And unfortunately, is probably one of the most important for diagnosing UIP. Let me get to it. So here you go. 42-year-old woman, worsening dyspnea over a year. Get the CT. Is it abnormal? What do you all think? Look at the bronchi. They're pretty dark, aren't they? Is she in expiration? No, she is not. This is all ground glass. This is an extensive ground glass problem. And is there imaging evidence of fibrosis? No. The pleura here is smooth. There's no traction bronchiectasis. I don't see any reticulation or honeycombing. So we go back to our differential. This is a patient who's got chronic ground glass with no imaging evidence of fibrosis. It's going to be one of these. It won't be alveolar prognosis. It won't be that though. Maybe a hypersensitivity pneumonitis. Doesn't really look like DIP. So I'm going hypersensitivity pneumonitis. Noah, you were right. Now, is this extrinsic allergic alveolitis from breathing in, or is this hypersensitivity pneumonitis from blood in intrinsic form? Remember, hypersensitivity pneumonitis has two forms. Is it something she's breathing, or is it something in her blood? And what you do is you look and you're like, this is very uniform. There might be a little central lobular nodularity, but most of it is uniform. So if I was a betting man, I would roll that this is probably in the blood. And it turns out this is a drug toxic reaction to Prozac. Yeah. So because the disease is pretty severe here in the lower lobes. That doesn't tend to see when you breathe it in. So NSIP is an inflammatory pattern, and it's seen often in the setting of collagen vascular disease or hypersensitivity pneumonitis, but it's the pathology. Okay, this is an etiology. Usually it's ground glass. There's two types on the spectrum: cellular, which is not a lot of fibrosis, or this is actually more fibrosis, you call it fibrotic. It is not a diagnosis in itself. So even though the pathology in this case was cellular NSIP, the etiology was hypersensitivity pneumonitis from drug toxicity. If you keep taking a drug or you keep getting exposure to something, it can be hypersensitivity pneumonitis at first, or DIP, or organizing pneumonia. But if you keep, the etiology keeps insulting the lung, it eventually becomes NSIP. So NSIP in itself is not a diagnosis, it's a pathology. And it can be caused by any of these other ones. That's where the etiology or the injury continues. Okay, so everything sort of funnels down to NSIP, and then if NSIP, if the injury is still going, will eventually funnel down to UIP. Okay, all right. Ground glass process, emphysema, irregular visceral pleura, some reticulation here. You can see this patient was treated with steroids. They had cellular NSIP. Most of it improved. What was residual was fibrotic NSIP. The etiology in this case was not known. All right. This is another hallmark. When you see traction bronchiectasis, reticulation, irregular visceral pleura, this is pretty severe fibrosis. Is this UIP or is this fibrotic NSIP? Really, that's kind of where you're at. I mean, that's the two pathologies, people. All of those others, not really. They could have been and then weren't treated and eventually funneled down into fibrotic NSIP/UIP. Here is an important distinction. It's bronchovascular, radiating from the hilum. UIP doesn't do that. Second, subpleural sparing. There's no honeycombing here. This is fibrotic NSIP. How sure are you? I'm pretty sure. What's the etiology? I'd go back and see what was there before. Maybe it was previous COP or something that wasn't treated, but that's fibrotic NSIP. Honeycombing almost never occurs with some of the other ones. It occurs about 7 out of 100 patients based on a pathology study with fibrotic NSIP. When you see honeycombing, it's most likely UIP. That is a different category. That is a non-inflammatory based that requires a different therapy. So this is a patient with reticulation, irregular visceral pleura, traction bronchiectasis. Yeah, this is going to be advanced pulmonary fibrosis. It's more peripheral. That's UIP. That's right. That's UIP. UIP is peripheral and basilar most of the time. All of the findings of fibrosis should be there. The big one is honeycombing. If you say honeycombing on your report, they're going to get treated like UIP. And I want you to know that these pathology is no longer the gold standard for these. A lot of the prognosis is correlated with the imaging on CT. So you can't say, well, it's pulmonary fibrosis, non-specific pulmonary consultation. You got to go a little further. You got to try to look for this, because this is where the prognosis really gets altered. Honeycombing, UIP. If you don't see honeycombing, it still could be UIP, but if you start seeing the bronchovascular distribution and subpleural, it's most likely fibrotic NSIP. Again, this is for patients with the ground glass advanced pulmonary fibrosis. In your macros, have a macro for ILD. In your macro, you need to have these 3 things in there. Do you see pulmonary hypertension? Do you see a new nodule? Do you see ground glass without fibrosis? These are the 3 major complications of advanced pulmonary fibrosis, especially UIP. These are important, and they are almost always missed. Honeycombing. This is what honeycombing looks like. It's a cystic lesion, thick-walled, tends to share. It contacts the pleura. It has got to be right on the pleura. If it's here, that's not honeycombing. That's not honeycombing. That's subpleural sparing. It's got to be up against there. And it can be single file if it's early. As the honeycombing progresses, it migrates centrally. Okay? You can see what it looked like here a few years later. It's starting to build up, going centrally, right up against the pleura. Anybody see anything else on this exam in a patient with UIP? Once you see honeycombing and it's peripheral, that's UIP. They're not going to biopsy. That's UIP. 3 years later, they're having problems. What's the problems you're seeing on this scan? Anyone? It's tough. Don't worry, it was missed by the radiologist. And the pulmonologist missed it. What you see is very good. Mohammed, very good. The pulmonary artery is much larger. I know I didn't give you the soft tissue windows, but the pulmonary artery is much bigger. This patient is developing pulmonary hypertension. That's a bad sign. That needs treatment. The other thing you see are new areas of ground glass here that don't have fibrosis. And when you see that ground glass without fibrosis, that may be the acute deterioration phase that represents diffuse alveolar damage and is of not a good prognosis for patients with UIP. That usually means there's an inevitability to death within a few months unless this is addressed, and even that treatment doesn't work too well. Okay, so we're going on. Moving on. Okay, UIP. What do you see here? Honeycombing right up against the surface. Honeycombing, reticulation, irregular visceral pleura, spiculated nodule right apex. What is that nodule? It's lung cancer. Differential is lung cancer. It could be a zebra, it could be lung cancer. And that cancer will be adenocarcinoma or squamous cell carcinoma. It turns out in patients with pulmonary fibrosis, especially UIP, the incidence of lung cancer is 4 times greater than those with advanced emphysema. I said that right. The greatest risk for lung cancer, just based on probability, is pulmonary fibrosis. Because of all the metaplasia and stuff that goes on, these cancers pop off left and right. Any new nodule should be considered a lung cancer until proven otherwise. So what are the three things you look for? Lung cancer, a nodule, pulmonary hypertension, ground glass without fibrosis. Okay, very good. Okay, inspiratory expiratory imaging is really helpful in these patients with ILD, really helpful. So this patient has ground glass, has a little reticulation. On expiration, you see these areas of air trapping. When you see areas of air trapping in these patients with, ground glass, irregular visceral pleura, fibrosis, not UIP, by the way, then the air trapping is a pretty good indication that this patient has chronic hypersensitivity pneumonitis, and that would be the extrinsic form, because air trapping is a common manifestation of chronic hypersensitivity pneumonitis. So this diagnosis would be findings most consistent with fibrotic NSIP, most likely etiology, given the patchy areas of air trapping, are chronic hypersensitivity pneumonitis / extrinsic allergic alveolitis, period. Is this UIP? No. That's important. Okay. So here's if anyone's interested in Lynch, this was a very good paper, Fleschner, and I thought they gave a very practical thing. So if you're thinking UIP, remember, pathology is not the gold standard, people. If you're thinking UIP because of the honeycombing, say it's typical or characteristic UIP pattern, no biopsy occurs. Probable, it's got all these findings, but you don't see any honeycombing. And then these other ones like subpleural sparing, bronchovascular distribution, air trapping, this is something else. This is NSIP secondary to something else. Okay, I'm going to move a little bit here because I want to get to the last couple. 66-year-old shortness of breath, abnormal chest radiograph. What do you see here? Traction bronchiectasis, irregular visceral pleura, lots of fibrosis / scarring. It's relative sparing of the lower lobes, although there's abnormality here too. What's its distribution? Upper lobe and bronchovascular. When you look in the lower lobes, you see some perilymphatic nodularity. So even in patients with very advanced cases of fibrosis or scarring, the distribution or clues are there to tell you what the underlying problem was. And sarcoid, very good, Alyssa, sarcoid, or Assissa, sorry. So it's sarcoid. And what you do is you look at the upper lobe, you look at the bronchovascular, there's sarcoid there in both. And then you look in the areas of less involvement, and you will see that there are those perilymphatic nodules. They're little beaded appearance. See how they line up? That's called perilymphatic, and that's very characteristic for sarcoid and lymphangitic spread of tumor. Okay, so these are nodules, perilymphatic, random, central lobular. These are random. Miliary nodules. And what you see here is that it's along the pleura, but they're also central lobular. So they're in both. These nodules vary in size. When nodules, whether they're miliary or just regular nodules, vary in size, that will be metastases. If they are similar in size, that will be granulomatous, such as sarcoid or miliary TB / histo. This was miliary histoplasmosis, thyroid metastases. Okay, these are perilymphatic nodules. They line up along the bronchovascular distribution, or along the bronchi and the septum. Okay, these are actually perilymphatic nodules. When it's more central bronchovascular, that's usually sarcoid. When they're more peripheral and they vary in size, nodules vary in size, that would be lymphangitic spread, perilymphatic, beaded, lining up. And lastly, this is central lobular. Central lobular can be sharper budding tree appearance, or it can be smudgy nodules. The key is they spare the pleura. They spare the pleura. So if you do not see any nodules along the pleura or fissure, that's likely central lobular, and that's airway related. Okay? Airway related. By the way, This is what extrinsic allergic alveolitis looks like, as opposed to the one I showed you with Prozac. It tends to be very centralobular because the organic antigen is inhaled, sets up shop in the respiratory bronchial, gives that inflammatory appearance. Okay, so with that, I'm going to just finish with not the cysts, this, because I need to show you this. You pull up a case and you don't know what it is. And you just calm down and you just say, look, I'm going to describe what I see here, the distribution, and then my recommendations. You see these patients with consolidative nodules. There's some bronchovascular consolidation. I do not see any fibrosis. I'm going to give a differential of an organizing pneumonia. Very good. Possible etiologies could be COP, but given the nodularity, think about infection. And but this patient has 2 months of symptoms, so it's probably not an infection, but we don't know that. Best thing to do at this point, go to open lung biopsy. And this turned out to be cryptogenic organized pneumonia, cellular NSIP. No etiology is found, did respond to steroids. This patient, worsening dyspnea, ground glass, traction bronchiectasis, irregular visceral pleura. You look at this and I'm like, I'm not sure what this is. I think it's fibrotic NSIP. I'm not sure the etiology. Turned out they had an open lung biopsy and the pathologist didn't know what it was. They had never seen anything like it before. So remember, when we don't know, remember, book about what we don't know is bigger than the book we do know. You will find these particular patients where even the pathologist doesn't know what they are. Last case. 32-year-old, worsening dyspnea through 3 months. There's some nodularity. There's some cysts. They got nodules along the pleura a little bit. It's worse in the lower lobes. I thought when I saw this that this was going to be Langerhans cell histiocytosis. This was early in my career. But these cysts, yeah, DIP would have been a good thought, but this nodularity was bothering me. So the other patient also had a pericardial effusion. So my report was these findings, remember early in my career, I think most likely represent Langerhans cell histiocytosis, period. However, pericardial effusion and cardiophrenic involvement is distinctly uncommon. Would recommend thoracic surgery consultation and consideration of open lung biopsy. That's what we did. Turned out it's widespread adenocarcinoma. And since then, I've seen this pattern of the cystic widespread adenocarcinoma a few times. Now I recognize it, but I didn't know it then. So if it's not characteristic for something, be careful about coming down really hard. You can say, I think it's Langerhans cell histiocytosis. However, this is distinctly uncommon, further evaluation with open lung biopsy. So with that, that was based on the report impressions. Normal, not sure if it's abnormal, consider a DLCO. It's characteristic, short differential, use the word if. And lastly, you'll see something you have no idea. Don't panic. Just describe what you see and give your recommendations. Feel free to ask questions or send me an email if you have any questions. But it's been a pleasure sharing this information with you.
Thank you so much, Dr. Gosselin, for this excellent 2 presentations, and we really appreciate you giving us 2 hours every time. And
No problem.
hopefully look forward to having you with us after in the new year. But we really felt your passion in teaching, and this is what kept us engaged throughout the 2 hours. And we really all appreciate your efforts and your teaching. Thank you very much.
My pleasure. Let me know if you want anything in the future. I'm always around.
It will be
Thank
our
you.
pleasure. And hopefully one day we see you in Egypt and the conference
Okay.
next July. Yeah.
All right. Sounds good. You all take care. All right.
All right.
Thank
Thank you
you
so
very
much, Dr. Marc. Thank you so much. نلتقيكم الجمعة الجاية إن شاء الله يا شباب إن شاء الله. شكرا دكتور أحمد، شكرا يا إسلام، شكرا جزيلا.
شكرا هشام، شكرا لحضرتك.
Thank you so much, Dr. Marc. السلام عليكم ورحمة الله.
My pleasure. My pleasure. All right.